Hello, good evening, and namaskar. It's a great pleasure to welcome you all for the third BCOS 2022 third Best Clinical Oncology Symposium. And this is done under the aegis of SOMEX Research and Health Organization. It's a pleasure to welcome you all. To start the sessions and the proceedings, let me have a pleasure to invite our session coordinator, Dr. Ankit Nehra. Good evening, Dr. Ankit Nehra, sir. He's a consultant medical oncology at SCG Hospital, Jaipur. So the stage is set. Over to you, Dr. Ankit, for the further proceedings, sir.
Thank you. Thank you for the kind introduction. And I would like to invite all the esteemed chairpersons, speakers, panelists, faculties, and participants for the third Best Clinical Oncology Symposium with the breast cancer agenda. And first, I would like to call Dr. J.B. Sharma, sir, who is a senior consultant and head Department of Medical Oncology at Action Cancer Center, Hospital, Delhi, for the welcome and introduction. Over to you, sir.
Good evening, friends and colleagues. Today, it gives me an immense pleasure to welcome you all for the third BCOS Best Clinical Oncology Symposium, which is organized under the aegis of SOMEX Research and Health Organization. The scientific committee has worked very hard and tirelessly to ensure we have very good scientific deliberation from the national experts. So my sincere thanks to Dr. Naresh Somani, Dr. T.P. Sahu, Dr. Manish Kumar for their great efforts. Truly appreciate the timely support from the pharma colleagues to make it happen also. So without much ado, let's have a meaningful clinical discussions and hope you all enjoy the academic feast. Thank you very much.
Thank you, sir. So, start our for the further sessions. I would like to invite the chairperson, who is Dr. B.N. Kapoor, sir, who is the director and Department of Medical Oncology, Yashoda Cancer Institute, Ghaziabad. To B.N. Kapoor, sir.
Yeah, thank you very much, Ankit, and thanks a lot, Dr. Sharma, for giving me this opportunity to chair the session. It's an honor to be part of this oncology meet. Lot of newer things is happening in lung cancer, and every day we find something new being coming in the treatment of lung cancer. Early stage lung cancer, which was the domain of only surgeon, now with the advent of immunotherapy, a lot of newer things as new adjuvant chemotherapy in operable lung cancer, especially in 1B and 3A, which was the domain of surgical oncologists only. Now, I believe the medical oncology will take over, and to deliberate upon it, I do invite my friend, Dr. Chetan Deshmukh. He is the consultant at Dinanath Mangeshkar Hospital, Pune, and to deliberate upon it, Dr. Chetan.
Thank you, Dr. Kapoor, sir. It is indeed a pleasure to see you all, and I hope to meet all of you in person soon. Give me a moment before I share my screen. Are my slides visible now?
Yeah, it's visible.
Great. Am I audible?
Yeah, you are audible.
Thank you. So, as Dr. Kapoor rightly said, neoadjuvant systemic therapy in lung cancer, is it coming back again? We all know that lung cancer surgery is the standard treatment for stage 1 or 2 disease. You perform lobectomies or video-assisted thoracic surgeries. In selected tumors which are more proximal or perihilar, their pneumonectomy or sleeve resections are done, and it is usually accompanied with systematic mediastinal nodal dissection or sampling. For stage 3, sometimes there has been a debate whether somebody should perform surgery or they should be subjected to chemoradiotherapy. But whenever feasible, surgery has always been the standard treatment for lung cancer, and rightly so, because these survival curves are shown over a period of time, and the topmost curve is for people who have undergone surgery and who are younger in age, less than 65, and over a period of 20 years, the follow-up survival time, over a period of 20 years, you still have a decent amount of people surviving for long. So if somebody has survived lung cancer surgery for more than 20 years, he can be proclaimed as cured of lung cancer. And as age advances, the survivors go on dropping, which is again expected of any big surgery. Now, there are always people who refuse surgery, or people who have medical issues and hence are not deemed fit for surgery. And these are people who are offered radiation therapy, but the prognosis is definitely worse than surgery. The overall survival with surgery for T1 lesion is 65-70%. It drops down to half, 30-35% with radiation therapy alone. And so is the case for T2 lesions. The 5-year survival is 60%, but only 20% with radiation therapy. So radiation therapy is not a very effective substitute for surgery. So there are always efforts being made to make a person more resectable or make him suitable for undergoing surgery. So use of chemotherapy before surgery was attempted in lung cancer as well, and it has shown to improve resectability and or even improve disease-free survival in lung cancer. This was a systemic review and meta-analysis of 12 randomized studies, which showed that preoperative chemotherapy improved overall survival, the p-value being 0.02. This was by Burdett et al. In 2006, but there were similar findings in other smaller studies as well. Neoadjuvant chemotherapy is something which we have been offering in many other illnesses like breast cancer and ovarian cancer, but somehow it has not found much acceptance in lung cancer. There was another study as recent as 2012 by Scagliotti et al., the CHESS trial, chemotherapy for early stages trial, where patients who were chemo-naive stages 1B to 3A were assigned to 3 cycles of gemcitabine followed by surgery or surgery alone. And this randomization was stratified by center, disease, and the primary endpoint was progression-free survival. Unfortunately, the study was closed prematurely after 270 patients. Nevertheless, amongst these patients, the chemotherapy response rate was 35.4% and the pathological complete response rate was 4%. And the complete resection rate was also slightly superior in the chemotherapy arm. The perioperative mortality was not very significantly different. And for all patients, the progression-free survival was 4 years for chemo plus surgery versus 2.9 years for surgery alone. There was a trend towards significance, just the p-value 0.09. But for patients who were 2B3A, slightly bulky disease, the median PFS for those who underwent chemotherapy plus surgery was 4 years compared to only 1.1 years for those who underwent surgery alone. So as the tumors got more bulky or slightly more advanced, the effect of chemotherapy was more pronounced. So the overall acceptance has always been low. The possible reason is either there were smaller number of operable patients, or there has been always a fear that with chemotherapy, the subsequent surgery may be difficult because of the toxicity of chemotherapy. And for locally advanced disease, there have been effective therapies like chemoradiotherapy with or without immunotherapy. So immunotherapy, we all know, we have been hearing about it, reading about it, and seeing immunotherapy presentations in the meetings for the past 3-4 years. Everybody knows that there are impressive results with immunotherapy in advanced lung cancer and even in patients with locally advanced disease. So it is logical to move them up the ladder and try these agents in the neoadjuvant setting. And this was the concept of the Checkmate 816 study. This study had patients who were newly diagnosed resectable stage 1B to 3A non-small cell lung cancer patients with good performance status and without any driver mutation like EGFR or ALK. Remember, these were all comers, though the stratification was made by staging 1B2 versus 3A and PDL1 more than 1 versus less than 1, but PDL1 was not one of the inclusion criteria. These patients, almost 360 patients, they were randomized to nivolumab, single agent 360 milligrams every 3 weeks along with chemotherapy, a platinum doublet, or chemotherapy alone, again 3 cycles, and followed by radiologic restaging. They had an arm of the immunotherapy doublet of nivo-EP, but that arm was taken off. And then these patients, after 3 cycles, were subjected to radiologic restaging, and if feasible, surgery was done within 6 weeks post-treatment. The additional adjuvant therapy was optional. The primary endpoint was the assessment of pathological complete response and the event-free survival by blinded independent reviewers, pathologists, as well as radiologists. The secondary endpoints was major pathologic response, overall survival, and time to death or distant metastasis. So the study had a fairly balanced population. It included a fair number of patients from Asia as well as North America and Europe. The majority of patients were stage 3A, 63 and 64% in both the groups, a fair mix of histology, and most of them were either current or former smokers. But remember, PDL1 negative patients, people who have a PDL1 expression of less than 1%, were also in great numbers, 44 and 43%, and in 7% patients, PDL1 was not evaluable. So almost half these patients did not have any PDL1 expression. So patients who received neoadjuvant chemotherapy, most of the patients on the Nivo chemo combination could complete their planned course of 3 cycles of chemotherapy. Not many people had to withdraw because of either study toxicity, and none of them, in fact, the number of patients withdrawing because of disease progression was only 1 in that group. And these patients could then undergo surgeries which were planned, either lobectomy or pneumonectomy. And 83% of patients in the Nivo chemo arm could undergo an R0 resection, which is considered the gold standard in any oncologic surgery, versus 78% in the chemotherapy arm. The primary endpoint, as defined earlier, was pathological complete response rate, and the PathCR rate with Nivo chemo combination was 24%. 43 out of 179 patients had a pathological complete response, compared to only 2.2% in the chemotherapy arm only. So the pathological complete response rate was definitely significantly more in the Nivo chemo arm. The PCR was independent of all the subgroups. None of the subgroups had any difference in the PCR, whether it was age less than 65 or more than 65, 1B2 versus 3A, squamous, non-squamous, smokers, non-smokers, and PDL1 positive or negative. This is more important, that irrespective of the PDL1 status, these patients did well and showed the same amount of PathCR. The event-free survival was 31.6%, the event-free 31.6 months in the Nivo chemo arm versus 20.8 months in the chemotherapy arm. The p-value was 0.005. The overall survival, the objective response rate is also important, because when you are looking at downsizing a tumor to make it surgically operable or resectable, then overall response rate is also very important. And there also the Nivo chemo arm scored over the alone chemotherapy arm. In the Nivo chemo arm, 31% of patients had a radiologic downstaging, compared to only 24% in the chemotherapy arm. The overall survival was also, the median overall survival has not been reached in either of the arms, neither Nivo chemo or chemo alone arm, and the p-value is 0.008. At this interim analysis, the p-value for overall survival was the boundary for statistical significance was 0.0033, and the value of 0.008 was slightly higher, so it did not cross the boundary for statistical significance. But probably over a period of time, these survival curves will hopefully go further apart. The main concern about any neoadjuvant chemotherapy is toxicity, which will cause delay or may have to defer local therapy, but this was not the case in this study. Nivo chemo arm versus chemo arm, the toxicities were more or less the same. The number of treatment-related adverse events leading to discontinuation were almost similar in both the arms. So to summarize, neoadjuvant chemotherapy has shown promise in improving resectability, pathological complete response rate, and event-free survival. Earlier studies also had shown it. The numbers have always been small for neoadjuvant chemotherapy, and there were safety concerns and concerns about delaying definitive local therapy, which may have an impact on the overall survival, and that is possibly the reason for the low acceptance of neoadjuvant chemotherapy in lung cancer. But now we see lung cancer screening is gaining momentum. So more and more patients of stage 2 and stage 3 disease are likely to get diagnosed. And for these patients, probably neoadjuvant chemotherapy may be a very good option. Chemotherapy with immunotherapy has shown promising results across all subgroups, irrespective of PD-L1 status. And hence, this combination may be the first line therapy for stage 3 or borderline resectable patients. Thank you.
Thank you, Chetan. You have deliberated the importance of immunotherapy and chemotherapy as neoadjuvant and resectable lung cancer very well. And probably in the future, this may be the mainstay of the treatment for the operable lung cancer. We have got a few minutes. If somebody has got any questions, you're most welcome. If there are none, we will move on to the panel discussion. Thanks a lot, Chetan, for a very elucidate presentation, and thanks from the organizer.
Thank you, sir.
We'll move on to the panel discussion, and to moderate the session, I would invite Dr. Bhuvan Chok, who is the consultant medical oncology at Max Hospital Saket and Gurugram. And the point of discussion in the panel is difficult mutations in the EGFR and ALK positive non-small cell lung carcinoma and how to tame them. Dr. Bhuvan Chok, please.
Thank you, sir. Thank you so much for the opportunity. And it's a very new and advancing topic, and I think it's very exciting to have a panel discussion on that. So can I know if my panelists are there? It will be. Am I audible?
Yes, sir. You are audible.
Can you see? Can you just tell me if all my panelists are there? Or
Sir, all are
Bhuvan, your voice is not very clear.
is it not audible?
Yeah, you are audible, but your voice is slightly.
I'll just. Am I audible? Is it better now?
You were better earlier. Okay.
Anyway, so I'll start the discussion. Can I just wait 1 second? Just I want to see the list of my panelists. So I have the panelists are Dr. Jatin Sareen. Are you there, Dr. Sareen? Yeah, I can see you. I think I can see you. Dr. Safalta, I think you are. Dr. Safalta, are you there?
Hi, Doctor. Yes, I'm here. Hi, Dr. Bhuvan. Yeah.
Hi, Dr. Mohit. Dr. Mohit would also be there, right?
Yes, sir.
Hi, so Dr. Jyoti Anand. I think Dr. Jyoti Anand, are you there? Dr. Jyoti? So Dr. Ankur Punia?
Yes. Good evening.
And Dr. Nadeem.
Yes, sir. Good evening.
So I think let me just call back Dr. Jyoti Anand. Are you there? And Dr. Ankur Punia. I think these are the.
Sir, both are here, sir.
Okay. Thank you. So I'll just begin then.
Yes, I'm there.
Thank you. So I think my slides will be visible. I hope they're visible.
Yes, sir.
So I think we'll begin with the first case. So this guy is a 59-year-old gentleman who is a non-smoker, has been a non-case of meningioma and has had a recurrence. And he was referred for a radiation, and then by the time radiation was happening, there was some bit of breathing difficulty, and so he was second time post-op. He was referred for radiation oncology opinion, but then there was some bit of difficulty in breathing, and he was evaluated to have right-sided pleural effusion. A CT scan showed that there were multiple parenchymal nodules in the right lung, with a few nodules along the pleural fissure and the pleural and the facial surfaces. the pleural fluid was positive for malignancy, and the PET showed that the disease was primarily limited to the right lung and pleura. So he had undergone pleural biopsy. It was suggestive of a well-differentiated adenocarcinoma, and the IHC was consistent with the TTF1 positive and napsin1 positive, and it was finally diagnosed as primary pulmonary adenocarcinoma. And the sample was sent for NGS, and report was awaited along with the PDL1, and he was started on pemetrexed cisplatin. So I would like to start with a very basic question, Dr. Jatin. What do you prefer? Do you still do the individual mutations, or you prefer the NGSs to begin with?
No, I prefer NGS. I prefer NGS because uncommon mutations and all those things we cannot really catch on the individual testing by PCR and all.
Fair enough. Is there anybody in the panel who generally prefers to send for individual mutations, or does everybody widely agree upon that we send NGS these days?
Yeah, so if we have affordability issue, we think that patient is poor, he cannot afford later these drugs. Possibly in that case, there's no fun of sending those things, because sometimes they cannot even afford the basic investigation. In those cases, we have like components from different companies, so we'll be like EGFR or so at least we'll do, and those drugs, at least anti-EGFR, we can give and we can get from Ayushman and all those schemes. So though otherwise, if there's an affordable patient, definitely would like to send NGS.
So does everybody agree on this thing? Because I possibly have a point to a slight contradiction, because in these days, I think the NGS along, because of those coupons, has come down to almost 8,000 rupees. And I think that's, I don't know, what's the coupon rate for the DDPCRs and ISCs? I think it probably will be more than that, because these days, I think most of the companies are doing an NGS at somewhere less than 10,000. So,
yeah, we agree for NGS. We are all agree for the NGS.
Dr. Fanta, what is? Please go ahead. Sorry for interrupting.
Yes, because nowadays there have been coupons, so NGS have become quite cheaper as such. So we'll prefer NGS rather than individual testing, which will be costlier if we go ahead with the individual testing. Yeah.
Dr. Sabab, you were saying something. Sorry to interrupt.
Yeah. So the issue is like, suppose we have anti-KR positive, so anti-RK positive, so he cannot. And the patient doesn't have any access. So in those cases, possibly say I work in a government sector where patient can not even afford sometimes a CT scan. It is not all patients like that. So in those situations, possibly it is not wise to send. So basically we have to tailor. We cannot say as a blanket, everybody has to go for NGS or as a single gene. So depending on the patient profile.
So I think we do agree with this opinion also. Moving forward, his mutation was sent, and it was both DNA and RNA NGS, which is a common thing these days. So genes were screened for all the DNA-based mutations and RNA-based mutations. He had the classical sensitizing mutation of L858R. However, he also had a mutation in the exon 19 and exon 20 insertion mutation was also there. So what I would like to ask my panelists is, would you want to reconfirm this in another lab? So Dr. Safalta, what would be your take on it? Would you want to reconfirm it in another lab, or are you satisfied with this report?
I have never heard this kind of mutation, like exon 20 mutation, exon 20 as well as in the 21. I have never heard about it. So yes, I would like to reconfirm, but then reconfirming also will take some time. Yes, the patient have been started on chemotherapy, so we have also time to reconfirm it. So I would like to reconfirm this.
Fair enough. Dr. Mohit, what would be your take on it? Would you want to reconfirm, or are you satisfied with the report?
I would like to ask one thing. I think it is insertion mutation. It's not insertion. It's mutation S768I. That's what I can read.
So it's a insertion. So it's a mutation.
In the mutations, then we have drug available. I think Lazatinib that covers this S768I. That's why, as for best of my knowledge, and the common compound mutation. So I think we can go ahead with the Lazatinib with this mutation L858R and S768I. Both are covered by Lazatinib.
Fair enough. So you think it's a complex mutation?
The
in which
compound
there is
mutation, yeah. I don't think it is insertion, it is mutation. So my take is to go for afatinib.
Fair enough. And Dr. Syed Nisar, what will be your take on it?
Yeah, I also somewhat agree with with Dr. Mohit. This doesn't seem to be an insertion mutation, the classical insertion mutation of exon 20, which is actually quite resistant to these TKIs. So I would also go for afatinib. And as far as rechecking is concerned, no, I think it is a fair enough report, and I won't go for rechecking. I think I would rely on these findings.
So, as both of you rightly said, this is exon 21 L85R and exon 20 S768I. So, would anybody be interested in the PD-L1 status of such a patient?
Not at present, at least.
Yeah, so two things. So once we do NGS, so in future we'll be seeing these complex compound mutations. So one thing important is that we have to remember that, say we had a patient deletion 19 or say some other mutation, then few patients, so they would feel good, then others will not do well as the others. So there may be other mutations which may interfere with the action of drug or which may prognosticate. So these are coming now. So like we had a clear-cut one common mutation, now we have another mutation exon 20. So possibly we may change from basically like erlotinib or even osimertinib to afatinib. But now like we have like P53 with these mutations, we have PDL high versus these mutations. These they prognosticate. We can at least tell the patient how he will behave. And with the combination, possibly afatinib is a good choice. And these compound possibly they fare well than only insertions.
Enough. So, what would be your plan ahead? Dr. Mohit, you said afatinib.
Yes.
So there is a good data as to osimertinib also for S768I. There is a phase 2 data. So patient also has a sensitizing mutation to L858R. And there is also, can anybody mute themselves? I think there's a lot of, yeah. So the patient, there's a phase 2 data for osimertinib for S768I G719X. So would you still want to go ahead with the afatinib, or you think osimertinib is worth a try?
No, I think I would like to go for afatinib. Reason being the response rate and PFS was slightly higher in the with the pooled analysis which was done for afatinib. As I remember, it was 78% response rate or so, 60 to 70%, and PFS was around 14 months for afatinib. In the osimertinib data, that was around say 55% was the response rate, and the overall survival was around, PFS was around say 10 months. So it was slightly less as far as I remember in this particular mutation. So I would like to go for afatinib in this particular patient.
So that is for the mutations if they have only S768. Now we are talking about compound mutation.
But in the compound, the data of afatinib was even better. It was 75% response rate or so, and the PFS was also good. That's what I remember.
All these data is happening for single mutation driven. So in the compound mutations, you have that paper with you?
So they have done subset analysis. They have done the compound as well, as far as I remember. But I don't exactly remember whether this combination was there or not. But they have done compound mutation data as well for afatinib, and it was as far as numerically it was superior. I don't know whether it is actual in this case is particular mutation or not, but it is numerically superior. That's what I remember.
Yeah. So you think afatinib? Anybody else would have to have a different opinion on it, and everybody agrees that we will probably go ahead with the afatinib only. Is there anybody in the panel discussion? So if I'm asked, I hope I have covered everybody. Dr. Ankur, you are there?
Yes.
So what would be your take on it?
Yeah, I would prefer to start with afatinib first, give the trial of afatinib rather than going for other options.
Fine. Dr. Jyoti, what's your take on it?
I also agree with my other panelists, so I will go for afatinib first and followed by other TKI.
Fine. Thank you. So we all understand that the way the paradigm has changed, and we also understand that there is a difference in the way the patients with driver mutation survive and without driver mutation survive. In today's modern era, the way we describe EGFR as classic and uncommon. Uncommons are generally exon 20 insertions and S768I, L861Q and G7-709X, in which afatinib or both osimertinib can be given. But as probably the panel and as I also probably would, so this is how you describe the EGFR mutation in today's world and era. There is exon 19 deletion, there is exon 21. The most common being N858R, which is around 12.8%. And these uncommon ones, H19, SX768I, and then 861Q, and then there are the others, which possibly we'll talk the other, we'll move to the next case. So the real world outcome is that the patients with a common mutation, they do better than the uncommon mutations, especially the exon 21. Moving forward, one second. So yes, similarly, I started the patient on afatinib 30 milligram, then escalated up to 40. The first, he seems to be doing well. The first PET scan will be done soon. Moving to the second case, this is a 74-year-old male who is a non-smoker. He presented in December 2021 with breathlessness and found to have pleural effusion. Evaluated and no malignancy was found at that time, and he was started on ATT. Again presented to the hospital in January 2022. This time, for the same complaints, found to have malignant pleural effusion. PET CT suggestive of lung mass, pleural-based mass, and adrenal bone mets. MRI brain is normal. A CT guide biopsy lung has been done. It is again positive for adenocarcinoma lung. Has been started on nab-paclitaxel carboplatin the day 1815 Q4 weekly and sent for NGS. So NGS was again a 12-gene panel with the Ventana PDL1. The gene mutation is a non-frame shift insertion in exon 19, which there's a duplication of 2217 to 2234. The VAF is 61%. There is no other gene fusion or gene copy number relation. Question, would this to be treated as exon 19, sensitizing exon 19 or something else? So again, coming back to, I think we can start from Dr. Nadeem, if you're there. What would be your
yes. Yes. The sensitive mutation in exon 19 will be deletion, but not this shift insertion. It will, we won't consider it as a sensitive one.
So Dr. Jatin, what would be your take?
Well, I agree with Nadeem. I mean, this is not a sensitizing mutation. The classical deletion exon 19 is not the mutation. So I won't consider, as said by Nadeem.
Dr. Mohit, what would be your take on it?
I don't think it is sensitizing as far as I remember. That's not among the list of sensitizing mutation.
Fair enough. You think it is a driver mutation?
Difficult to say.
VAF is 61%. If somebody has a VAF of 61%, probably it is.
It looks like it's important, but I don't think our first line or second line or third edition medication are effective against this, as far as I remember. The EGFR inhibitors.
So there is, anyway, we'll talk about that. So Dr. Safalta, what would be your take on it?
Yes, I agree with the other panelists because that is a deletion manner. This is different.
Would any of you would want to reconfirm it with another lab? Seeing that it is exon 19, had it been exon 20 insertion, you probably have had a sensitizing mutation. Anybody who would want to reconfirm it with another lab?
We don't think there is any point. They have detected mutation, but that's our call whether we have any drug or not.
So, would anybody be interested in a PDL1 levels of such a patient? So, Dr. Ankur, would you be interested in a PDL1 level of such a patient?
Yes, I would like to do PDL1 for such a patient in which we don't know whether the TKI will be helpful or not. So, I will like to see.
I probably disagree with you because I think it is being driven by EGFR. Do you think a tumor which is being driven by EGFR immunotherapy will act? And I'm just being a devil's advocate here.
We don't know because so just for the option, I would like to get a PDL1.
Dr. Jyoti, what is your take on it?
You're right in saying that when we have EGFR mutation, it is PDL1 sensitive status does not change. Like anti-PDL1 therapy doesn't work well on such patients. But since we are saying that this is not a sensitizing mutation, then we should go for PDL1 testing.
No, so I think we go for PD-L1 testing primarily because we don't have EGFR therapy, or primarily because it's being driven by EGFR. As in, just because I don't have a therapy, is it an indication for me to go for a PD-L1? Is what I'm discussing, rather asking.
Sorry.
See, the point is, it is being driven by EGFR. I may not have a therapy for it as yet, but would a immunotherapy be working in such a tumor?
Difficult.
Immunotherapy alone is not a good option. That's what I feel. We can think about adding if it comes out to be high. That's my take. But we can't rely solely on PD-L1, anti-PD-L1 therapy if we have EGFR-driven mutation.
Fair enough. Go ahead. Sorry, Mr.
Yeah, so this is again possibly a driver, although it is an uncommon mutation, and response to anti-EGFR will be low. But definitely these cases, they respond poorly to immunotherapy. So that we have to take into consideration.
Dr. Safalta? Sorry, I'll just go. So what would be the plan ahead? I don't think we have the time to go through the newer exon 20 insertion, which probably we're going to be discussed moving forward by the other speakers. So what would be the plan ahead? What would be your plan ahead, Dr. Safalta, for it? I'm actually struggling with this patient.
In vague memories,
Or I
what I
can,
remember is that.
मैं इसको Saturday के ट्यूमर बोर्ड में डाल सकता हूँ if you want.
See, actually, the thing is that in a vague memories of what I remember is that the deletion 19, yes, they will do good with osimertinib, but then here it is an insertion mutation, and this entity exists, and these type of patient, they do well with afatinib. They are some uncommon EGFR mutation, and they do well with afatinib or a combination. That's what in vague memories, right?
Do you think afatinib is worth her trying such a patient? Hello?
We'll have to check the details. I think whether it was mentioned in the trial or not. If it is not, then there is no.
You tell me, so okay, Dr. Mohit, what will be your one take on this? What will be your advice to the patient?
For preferably, I think I would like to go for chemotherapy, and I would like to reserve checkpoint inhibitor for future.
So I'll get it. So you would like to continue chemotherapy, is what you say. Would you want to add BEV to it?
BEV in the first line, adeno. You're talking about the trial, the IBC. I am not quite fan of use of BEV in
CNS. That is the only place
I'm talking about honestly.
No. So I'll take you through this data which is there. Yeah. So basically, so this is exon 20 insertion. This is not exactly this, but then a chemotherapy alone versus a chemotherapy BEV data. There's an improvement in the PFS. So would any of you want to be, if anyone choosing to continue with chemotherapy, would you be interested in adding BEV to it?
Yes, possibly it is worth it. You should add Bevacizumab.
So
I think it should be for exon 20 insertion. That's it. This was exon 19.
ये तो आप मतलब बाल की खान में, but हाँ, then I understand what you say. अगर data दिखाए रहे हो तो पूरा दिखाओ. But then fair enough. So coming back to it, we have understood that none of us will probably be more comfortable in adding immune checkpoint inhibitor, and if at all, so Dr. Ankur, what would be your take on it?
Yeah, if not, I'm not giving an immune checkpoint inhibitor, then I'm going to give chemo plus BEV combination.
No. You are allowed to give anything, yaar. तुम बताओ क्या देना है. So by the way, his PD-L1 is negative. Sorry.
Then I will go for a chemo plus BEV combination.
Dr. Jyoti Anand, what would be your take on it?
Well, I would like to add the Bevacizumab to the chemotherapy arm.
So, is there anybody else who would differ from this? Possibly we are doing chemotherapy plus minus BEV after talking to the patient. I think Dr. Syed, is that also your opinion?
Yes, sir. Yes, sir. I agree.
Right. So, sorry. So I have kept the patient on nab-paclitaxel carboplatin without Bev. There is data to suggest some use of afatinib in this. However, I am not confident enough to replace the ongoing therapy because he's responding to the therapy. I plan to use afatinib as a maintenance regimen in him because there is some data which I researched about. I can share the papers if you want. So my plan is to continue at least 5 to 6 cycles with the therapy and then add afatinib as a maintenance therapy. That's my take. And I think you're also, I've finished my 25 minutes. If the organizers, they have time, I can take you through the data for the EGFR insertion. Otherwise, I think I would like to wrap it up.
Sir, we do have 10 minutes. Sir.
Oh, yeah. You want me to give her a presentation also? It's okay. मतलब I can give you my data बना रखा है, but then I thought ये तुम Chrysalis 2 anyway present करने वाले हो, but I think that data is very good. Chrysalis 2 का जो
yes, sir, yes. The Chrysalis is the next discussion only, sir.
हाँ, so I think Chrysalis 2 का data है, and then there is, so what I rather wanted to take through this is जो इसका data है वो नया. This certain का data है, and then I ये जो Chrysalis sorry, I am interested in, I just wanted to discuss this. Sorry, I don't have the presentation. I was reading for it. Chrysalis का जो let's see if I have the data for this. I think लोगों को wrap up भी करना होगा. If I am sorry, I don't have the presentation right now, but there's this data जिसकी जो उसमें 4-5 हैं, and जो वो बोल रहा है ना, जो Mohit also was saying that. Mohit, have you seen through that CCO presentation है एक, which is a very good presentation itself. Anyway, so organizer, I would request you to wrap it up. I have lost those slides, but then there is this जो Chrysalis का नया data है, that is very good. Thank you all for such active participation, and I hope there was some use to these cases. That's about it.
Thank you.
Thank you.
Organizers, back to you.
Thank you so much, sir, for such an immersive and very interactive discussion. So our next session is Chrysalis 2 updated results of Amivantamab with Lazatinib in patients with EGFR mutated advanced NSCLC post osimertinib and platinum doublet chemotherapy. To talk about it, I would like to invite Dr. Vikas Talreja, sir, who is a consultant medical oncologist at Regency Hospital, Kanpur. Dr. Vikas, sir. Is Vikas sir there?
Yes, sir. He is joining in 5 to 10 minutes.
So can we take the next session? If Siddharth Tukar sir is there?
So just give me 5 minutes. So Mani sir, can we do a question and answers?
So can we just wait for a minute? I think Dr. Siddharth is joining and Dr. Vikas is also joining in a minute.
Okay.
Yeah. If you have some questions, we can have some questions answers.
So if there are any questions. I think the chat box is also empty. No questions.
Dr. Vikasa, can you hear us, please?
Consultant medical oncologist at Regency Hospital, Kanpur. He will be talking about Chrysalis 2 updated data of Amivantamab with Lazatinib in the patients who have already EGFR positive patients who has already progressed on osimertinib as well as platinum doublet combinations. Over to you, sir.
Thank you, everybody. Wonderful conference, a beautiful agenda, and I hope I'm audible and my slides are visible. It is a very important topic, as we have seen that lung cancer hasn't been the same as we started our journey, and it has seen a humongous change since the treatment paradigms over the last few years. And to add to that, we have a newer molecule, a newer kid on the block, that's the Amivantamab and the Lazatinib in the patients who are EGFR mutant positive non-small cell lung cancers after the progression of osimertinib and platinum-based chemotherapies, the Chrysalis 2 trial. So next slide, please. We know that in initial results with amivantamab and the Lazatinib, they were showed an increasing efficacy in patients whose disease has progressed after the standard of care with osimertinib and platinum-based chemotherapies. That was one of the cohort of the Chrysalis study, which was designed on the same basis. And the cohort A, next slide, evaluated the amivantamab and the Lazatinib in patients with EGFR exon 19 or L858R mutations whose disease had progressed on either the first line or on the second line osimertinib, followed by the patient on chemotherapy as the last line of therapies. The target population was around 106 of them, and among a more heavily pre-treated populations, that is 56 of them, whose disease has progressed after the osimertinib and the chemo options and other therapies without the regard to the lines of which the therapy was given and the sequence at which these therapies was given. So next slide, please. Patient received 1050 milligram of amivantamab, that is more than 80 kilogram patients received 1400 milligram of it, and 240 milligram of oral Lazatinib. It was an investigator and as well as blind independent central review assessed patient response criteria and defined as patients who initiated the study treatment on or before 17th March 2021, allowing more than 6 months of the follow-up for the response durability. As of November 6, 2021, next slide, 162 patients were enrolled in the cohort A with a median age of 62 years, 65% being women, 61% being Asian as divided by the EGFR mutation type, and the median lines were around 3. So the range was 2, that is osimertinib and paclitaxel or the PEM-cabo, and the upper range went up to 14 lines of therapies where the physicians and the oncologist choice of treatment was dictated. And the median treatment between the last osimertinib to the first dose of amivantamab plus Lazatinib was 6.3 months and 2 months for the target and the heavily pretreated populations. Of the 50 efficacy evaluable patients in the target population, the overall response rate by the blind independent central review was 36%, 95% confidence interval being 23 months, the upper limit being 51%. So half of those patients who had been heavily pretreated had some response rate, and 17 were the partial responses, and the clinical benefit rate, which includes also the stable disease, was 58%, the upper limit being 72%. So 72% of the patients who had been again heavily pretreated in EGFR mutation positive patients post osimertinib, post chemo, where we run blind of what to do next, this combination proved to be an highly effective combinations. The duration of response was not reached based on the blind independent committee review at a median follow-up of 8.3 months. 7 responders have achieved a durable response, and the duration of response lasted for more than 6 months in 40% of these patients. The investigator-assisted responses were consistent with the blind independent central review responses. Of the 56 efficacy available patients in the pre-treated population, overall response rate by investigator was around 29%, with 1 complete response and 15 partial responses. The clinical benefit rate was 55%, and the upper limit being 69% of it. And the median duration of response was 8.6 months. The upper limit of the median duration of response was not achieved. The blind independent central review was still pending. So to conclude, activity was reported among 8 patients with baseline brain metastasis, 7 non-target and 1 target, who had not received radiation within last 1 year to the study enrollment. The most frequent adverse events were the infusion-related reactions, 65%, the paronychia, that is 49%, rash around 41%, and stomatitis around 39%. All of these being the medical oncologist domain to handle along. The most common grade 3 treatment related adverse events were the infusion related reactions, acneiform dermatitis, and hypoalbuminemia. The transfusion related adverse events leading to the discontinuation of either the both amivantamab or the Lazatinib occurred in around 12 to 7% respectively. So to conclude, among an unselected population that has exhausted the standard of care osimertinib and the patient and the platinum chemos, Amivantamab and the Lazatinib demonstrated an encouraging anti-tumor activity with a manageable safety profile. And this definitely is an encouraging trial to look forward to, especially when we run out of osimertinib and the chemo options. The Amivantamab and the Lazatinib does have a very promising future ahead. Thank you, organizers, for giving me the opportunity, and thank you. Would love to have answer any questions if there are any.
Thank you, sir, for a very interesting data and very interesting talk. If there are any questions, I think there are no questions in the chat box as well. Moving forward to the next session, I would like to invite Dr. Siddharth Tukar, sir, who's a consultant to Siddharth, sir.
So, yes. So Dr. Ankit, Dr. Siddharth is joining again because there's some issue. He joined and then he just left. There's some issue in his connection. Maybe we just wait for a minute.
Sure.
Yeah, and then we will invite Dr. Devrat Arya because Dr. Sham will join by 7:45. So after Dr. Siddharth's talk, we will take Dr. Devrat Arya's talk. He's joining also.
Sir, I would like to invite Dr. Siddharth Tukar, sir, who is a consultant medical oncologist at Narayana Super Specialty Hospital, Raipur. He'll be talking about Checkmate 816 study data, which is evaluating neoadjuvant nivolumab with chemotherapy versus chemotherapy alone in resectable non-small cell lung cancers, about the pathological regression rate and event-free survival. Over to you, sir.
Yeah, Dr. Siddharth, can you see the slides? We just say next, so my colleague will, do the next slides. Hello, Dr. Siddharth.
Still not visible. It is still not visible. Is it visible to all other?
Yes, yes, the slides are visible to us.
Okay. It's not visible to me.
Hello, Siddharth sir, can you hear us now? आपको अनम्यूट करना है. If you can unmute, please. Dr. Siddharth, can you unmute, sir? I think you have.
Hello.
हाँ, sir. Now you can
Hello?
say, please start your presentation, sir. Over to you, sir.
Oh. New adjuvant nivolumab plus platinum 816 trial. So I will be presenting regarding association.
Sir, you are not audible.
Dr. Devrath sir, thank you so much for joining. Is it possible for you to take the presentation? Can you hear us, please?
Hi, Tarun, I can do that, yes.
Okay. So, Surbi, can you just stop the presentation? We'll request Dr. Siddharth to do that afterwards. So, Dr. Ankit, we have Dr. Devrath sir with us. Can you just introduce Dr. Devrath and we can have a presentation, please? Dr. Ankit, you're there? Hello, Dr. Ankit, can you hear us? Hello? Hello, Dr. Ankit, can you hear us, please?
Sir, I would like to invite Dr. Devrath Arya. He is a director and medical oncologist, Max Hospital, Saket. Sir, kindly proceed.
Yep. So thank you very much for this opportunity to the organizers. I hope my slides are visible.
Yes, sir.
Okay. So this is obviously a sponsored talk. So the mandate given to me is to talk about Lazatinib, a frontier in the first-line treatment of ALK-positive non-small cell lung cancers. So we know that non-small cell lung cancer is a heterogeneous set of disease. We know that adenocarcinomas, or in fact, majority of non-small cell lung cancers have now been defined by the presence of oncogenic drivers. One of the first oncogenic driver to be recognized was the EGFR mutation. This kind of set a template of how to actually put forward personalized precision medicine, especially in the landscape of this disease. And since the detection of EGFR, in fact, we've had a number of other biomarkers. Some of them are targetable, others unfortunately are not. So we have EGFR, we have KRAS, we also have in decreasing numbers ALK, BRAF, HER2, ROS1, RET, etc., etc. Now, the mandate today obviously is to talk about BRAF, the ALK rearrangement. So we know that estimated prevalence of ALK rearrangement is up to 7%. We know that there is a clinical profile that is associated with ALK rearranged non-small cell lung cancer. So these patients typically are younger patients. Median age of onset of disease is a decade younger than the non-ALK rearranged non-small cell lung cancers. Most of the patients would have a no smoking history or a very light history of smoking. And the incidence of brain mets, is actually a lot more common in the ALK rearranged non-small cell lung cancers as compared to others. Now we know that molecular technology preference varies according to different target, analyte, and variant. We know particularly for ALK, you have different ways of assessing the presence of rearrangement. I'm sorry, can I request everybody to put their
link?
Ms. Surbi, can you please put yourself on mute? Yeah, so there are different ways of assessing ALK rearrangement. So we talk about FISH, we talk about NGS, we talk about IHC. We also know that PCR is another way of assessing ALK mutation. I think the advantage which NGS is, it can look at both DNA and RNA, and it looks at multiple alterations, which include single nucleotide variants, insertions, deletions, copy number variants, and fusions. And I think the other advantage in a setting where tissue is always an issue, when a clinical oncologist, the medical oncologist is always short of tissue, is that you have one-stop assessment of all possible driver mutations, and therefore one can pick up. And I think when we look at ALK rearrangements out of IHC, NGS, FISH, perhaps the greatest concordance is actually between IHC and FISH in terms of their ability to pick up ALK rearrangements. So, as I said, if you do individual testing, you are going to have a need for a larger tissue volume because you'd actually be testing in all the driver mutations individually. But a multi-gene testing, and that's where the world seems to be moving, is what is advisable, and increasingly NGS is being used by most practicing oncologists to be able to assess individual driver mutation in a limited amount of tissue. So guidelines, now all guidelines, in fact, non-small cell lung cancer was one of the first lung cancer where guidelines recommended NGS testing. So when you look at NGS, NCCN, you have a recommendation of broad molecular profiling for established and emerging biomarkers, and it's a whole gamut of biomarkers. It includes EGFR, KRAS, BRAF, ALK, MET, RET, ROS1, NTERC, and PDL1. And in fact, the same guidelines are recommended by ESMO as well. So one could potentially test individually for these markers or do a broad based, multiplex or a broad NGS testing. Now, as I said, the challenges are there with NGS. So clearly, benefit is that it's a reliable way of detecting standard of care mutations with a high sensitivity and specificity. There's also accurate identification up to 3 times more clinically actionable alterations compared to current diagnostic tests. May provide data for all known mutations, which may have access to targeted treatment, not only in first line, but also in later lines. And it seems, at least in the Western world, but also increasingly in India, that it's feasible to do an NGS. And while the turnaround time is a little bit of a negative, it seems acceptable. I think the challenge is the cost and investment required, not only by the lab, but also the cost of individual tests. Technical challenges there, you really need to look at the quality of testing. And while DNA testing is easier, RNA is more difficult. Fusions are usually missed. Accessibility is also important. There's a potential of false positives. And then lastly, turnaround time as compared to individual tests, EGFR, ALK, ROS tested individually, you have the results in a few days. NGS would usually take 2 to 3 weeks for the results to be there. But clearly, one can have a more, limited testing like what Novartis seems to be doing. They have a limited test panel which should look at all the relevant DNA-based mutation like ALK, BRAF, EGFR. They would also look at fusion genes, and some of that is RNA-based sequencing, particularly relevant for ROS1, RET, ALK, and MET. So, this is an example where you could have a targeted NGS, which also, in fact, adds PDL1 for those patients who have a high PDL1 and the biomarkers are negative. So, this actually allows us to screen cost-effectively patients for the relevant biomarkers in non-small cell lung cancer. And possibly this is the answer that India or Indian labs have to the issues with regards to cost and challenges associated with cost in our setting. So coming to Lazatinib, we know Lazatinib has been available worldwide and in India for quite a bit of time. And over the next few slides, I'm going to revisit some of the data that we have with Lazatinib. So I'll bring all of you back to the generational categorization of different ALK inhibitors, and we all know that Crizotinib was the first generation ALK inhibitor. In fact, it was one of the first drugs that actually, compared to chemotherapy, showed that ALK rearranged tumors actually responded better and longer to ALK-based TKIs. Then we have had a multitude of second generation ALK inhibitors, Lazatinib being one of the first second generation ALK inhibitor, and we've had others including Alectinib, Brigatinib, and Arsatinib, and of late we have also some initial data over the third generation ALK inhibitor Lazatinib. But we'll talk about ASCENT-4, which is a randomized phase 3 study which looked at first-line Lazatinib versus chemotherapy in patients with ALK rearranged non-small cell lung cancer. So this was a global phase 3 study. Patient needed to have ALK positive, locally advanced or metastatic non-squamous non-small cell lung cancer, had to be treatment naive, randomized to receive Lazatinib at the initial dose of 750, and we have had a lower dose approved now. So this was a fasting dose of 750 mg or randomization to PEM-CIS or PEM-CARB, and patients could receive the treatment till progression. There was an option of crossover to extension treatment for those patients who received chemotherapy, and stratification was as per performance status, presence or absence of brain mets, and prior receipt of neoadjuvant or adjuvant chemotherapy. Now, the primary endpoint was progression-free survival. Key secondary endpoints included overall survival. There are also other secondary endpoints that included overall response rates, duration response, etc. So what were the results? Lazatinib doubled the median progression-free survival compared to chemotherapy, and this is the blinded investigator result analysis. So median progression-free survival was 16.6 months compared to 8.1 months for chemotherapy. So Lazatinib doubling the progression-free survival. Overall response rates highly impressive at 72.5%. Duration of response was 23.9 months, and 24-month OS rate was 70.6%. So there was a 45% risk reduction of progression compared to chemotherapy. So clearly showing a significant advantage with Lazatinib or Spexib compared to chemotherapy. And importantly, when you look at the Asian patient subgroup analysis, and I think we've all recognized how important the Asian subgroup analysis also and how relevant it is. When you looked at the Asian data, first-line Lazatinib versus chemotherapy, there was a 34% reduction in the risk of progression or death. So clearly, there's an improvement not only in the global population, even in the Indian or the Asian population. Lazatinib actually led to an improvement in overall outcomes, progression-free survival compared to chemotherapy. Now, ASCENT-8, the Asian patient study analysis, we'll talk in a little bit more detail. So this is patients with advanced non-small cell lung cancer who were treatment naive, had ALK rearrangement being tested by the Ventana IHC or the FISH platform, excellent performance status. They were allowed to have brain mets, but these needed to be neurologically stable. And patients were randomized to either Lazatinib 450 mg with a low-fat meal, or Lazatinib 600 mg with a low-fat meal, or Lazatinib 750 mg. That was the assessed dose at that time under a fasted state, and Lazatinib could be continued in the progression. And the idea was to assess the steady-state pharmacokinetics of the lower Lazatinib dose, and the key secondary endpoints for overall response rate and duration response as per the RECIST criteria. So what were the results? Again, when you look at the Asian patient subgroup analysis, clearly Lazatinib led to an improvement in outcomes. And in fact, Lazatinib at the lowest dose of 450 milligram given after food was the arm which did the best, led to a overall improvement in outcomes. The hazard ratio for events was much lower for the Lazatinib lower dose, and the probability of improved outcomes was much higher with the lower dose. So this is the Asian patient subgroup analysis. So overall response rates fairly equivalent, in fact numerically higher for the 450 mg dose at 82.8% versus 79 and 76 respectively for the 600 and 750 dose. The disease control rate, again, very impressive at nearly 97% for 450 mg dose compared to 90% for the 670 mg dose, the 750 dose. Duration response was not evaluable at the time of analysis. So possibly the highest for 450 mg dose. Median progression-free, again, highest for the 450 mg dose. PFS rate at 24 months, again, more than double for the lower dose. And the overall survival rate also significantly higher at 93% at 3 years for 450 mg dose compared to 62 and 70 for the 600 mg dose. So clearly, the 450 mg dose given after food seems to be doing equally well, in fact, a lot better than the higher dose of Lazatinib. So, as we said, brain mets is a significant challenge for ALK positive or ALK rearranged non-small cell lung cancer. In fact, we have data to show that across study, the incidence at baseline may be as high as 31%. We know that brain mets can be a significant factor in terms of overall outcomes in these patients. And when you look at brain metastasis, in the ALK treatment naive patient, the number is 31 to 40%. But when you look at patients who've had, prior treatment, in fact, the number would actually go higher. Now, crizotinib, which was the initial standard of care, most of the patients, nearly half of the patients actually progressed or lapsed in the brain. And therefore, there was clearly an identification of a need for a next generation ALK inhibitor, which actually had a significant penetration of the blood-brain, significant crossing of the blood-brain barrier, because that would then add value to treatment in the first line setting. So what about ceritinib from the two ASCENT studies? So when you look at ASCENT 4, you look at PFS for patients who had brain mets, there was a significantly longer PFS with ceritinib, 10.7 months compared to 6.7 months for chemotherapy for those patients who had brain mets. And when you look at those patients who did not have brain mets, both the arms were doing well. But ceritinib, again, similar to those patients who had brain mets, was doing better than chemotherapy. When you look at intracranial response rates, the intracranial response rates were significantly better with ceritinib compared to chemotherapy, 72.7% and nearly 46% higher compared to chemotherapy, which sat at about 27%. A significant number of these patients achieving response, achieving durable response with ceritinib as compared to conventional chemotherapy. Again, looking at the Asian subgroup analysis, when you look at the Asian subgroup, again, ceritinib achieved a higher overall response rate and disease control rate compared to chemotherapy, and the median duration of response was not reached at cutoff date. And even in the patient who had measurable and non-measurable neurologically stable brain mets, ceritinib achieved a higher overall response rate, overall intracranial response rate, and overall intracranial disease control rates. So there have been other studies. When you look at different analysis, and one of these analyses was the comparative efficacy of first-line ceritinib and crizotinib in ALK rearranged tumors. We had a lot more current smokers in ASCENT 4. We had a lot more older patients in the ASCENT 4 compared to profile 1014. And, although this is a cross-trial comparison, ceritinib was associated with a significantly longer PFS, with the median PFS sitting at 25.2 months compared to 10.8 months. And in the adjusted indirect comparison, the ceritinib was associated with significantly prolonged PFS compared to crizotinib and significantly higher outcomes, better outcomes compared to crizotinib. And this is again a cross-trial comparison clearly showing that the median PFS for the second generation ALK inhibitor ceritinib looks a lot more favorable to the first generation ALK inhibitor, which is crizotinib. Coming to overall survival, again, there's no OS advantage with crizotinib, but when you talk about ceritinib, although data is immature, we are keenly awaiting that data. Now, what about safety profile? Now, safety profile, ceritinib actually improved quality of life, significantly prolonged time to deterioration for lung cancer specific symptoms compared to chemotherapy in the ASCENT 4. We are now very much aware of the safety data. So we know that while there was significant toxicity, including GI toxicity with nausea, vomiting, diarrhea with the higher dose that was tested, we also now know that with the lower dose of ceritinib sitting at 450 mg, these toxicities are lesser. And again, in ASCENT 4, the treatment discontinuation rate because of toxicity sat only at 5%, which compares favorably to most other ALK inhibitors in the first line setting. So what are the options that we have in the first line setting? I think the options have become wider with the availability of the other second generation and the third generation ALK inhibitors. But we know that crizotinib through profile 1014, lorlatinib, ceritinib, alectinib, and brigatinib are all all approved in the first line setting. Unfortunately, we don't have a head-to-head comparison between the different ALK inhibitors, and therefore it would probably be inappropriate to stack one second generation ALK inhibitor compared to a other second generation ALK inhibitor and say that this one is better. But we know what guidelines suggest, and all the guidelines suggest that Ceritinib is a recommended first line drug for patients with ALK rearranged non-small cell lung cancer. Again, I think when we talk about drugs, especially in a cost sensitive market like India, patients usually are paying out of pocket. Cost effectiveness is also important. And when you look at the combinations of ALK inhibitors that we can potentially use, so one could potentially use Ceritinib in the first line setting and then use Alectinib in second line and Lazatinib in third line. And it does seem that it seems to be a cost-effective option, giving the longest chemotherapy-free interval for those patients who have a ALK rearranged non-small cell lung cancer. So there are certain points to consider while using ALK inhibitor in the first line setting. I think clearly we have to use the drug which has shown the highest efficacy, because a lot of these patients would not be able to receive second line setting. Brain mets, even if patients do not have brain mets at baseline, brain is a site of failure, and therefore one needs to use brain penetrable ALK inhibitor to prevent brain mets. And obviously for those patients who do have brain mets at baseline, there's a enhanced reason to use ALK inhibitor with enough CNS penetration. We want agent with a rapid response, especially for those patients who have systemic disease. And clearly, as a medical oncologist, in my mind, I would create a continuum of care, and I would usually have a first line option in my mind and then have a possible second line option for most of my patients with this disease. And so I'll quickly conclude and say that in the ASCEND-4 trial, in the ALK inhibitor naive population with ALK positive non-small cell lung cancer, Ceritinib showed significantly improved PFS and numerically improved OS, although data is still not mature. PFS benefit was also seen regardless of presence of brain mets. So patients, even with patients who had brain mets, Ceritinib did well. Gastrointestinal adverse events with Ceritinib were manageable with least grade 3-4 adverse events. And efficacy and safety of Ceritinib has been well established even in the Asian population with ALK rearranged non-small cell lung cancer. And clearly, it's for this reason that Ceritinib still is category 1 recommendation by most guidelines for usage in this subpopulation of patients. Thank you very much for your patient hearing, and back to the organizers.
Thank you so much, sir, for the wonderful and informative session. So if Siddharth sir is there, can we call him for the
Dr. Siddharth is there, so you can call him.
Okay. So I would like to invite Siddharth Tukar sir, who is a consultant medical oncologist at Narayana Super Specialty Hospital, Raipur. So he'll be talking about Checkmate 816 trial for comparing neoadjuvant nivolumab with chemotherapy versus chemotherapy alone in resectable non-small cell lung cancers. Over to you, sir.
Please share the slides.
Yeah. Surbi, can you just share the slides, please?
Sir, can you see the slides?
So I think everyone is, yes, I can see the slides. So chemotherapy versus chemotherapy of pathological with event-free survival in Checkmate 816 trial. Next slide. Coming to the background, several studies shown an association of pathological response, a common efficacy endpoint in neoadjuvant therapy. This covers cancers
Dr. Siddharth, sir, your voice is not clear. Sir, your voice is not clear at all. So, आप थोड़ा सा range पे आएंगे because I think you have a poor network still. So, Subhi will just wait if he joins, because I'm just trying to connect with Dr. Shyam Agarwal.
Okay, sir.
Sir, I've just spoken to Dr. Siddharth. I think next 2 minutes is joining, and then we'll take Dr. Shyam Agarwal's topic. He's also joining. So we just have to wait and watch, sir. We'll just wait for some time. Yeah.
So I will be presenting a post-hoc analysis from Checkmate 816, characterizing the association between pathological regression and event-free survival. Next slide. Coming to the adults with resectable non-small cell lung cancer were randomized to nivolumab 360 milligram plus platinum doublet chemotherapy or chemotherapy alone for 3 weekly cycles for 3 cycles. The primary endpoints were event-free survival and pathological CR, that is 0% residual viable tumor in primary tumor as well as lymph node based on immune-related pathological response criteria, both assessed by blinded independent review. The major pathological response. Hello.
Yes, sir, we can hear you. Go
Hello?
ahead, sir. हाँ sir, आवाज आ रही है. Please go ahead.
Okay, yeah. So in this post analysis, event survivors assessed in the primary tumor only. Also, a time-dependent receiver operating characteristic curve analysis
And Dr. Sudhir sir, Tarun here from Horizon. Sir, इसके बाद में ना, can you invite Dr. Piyush Bajpayee, please? He'll join.
Good evening, everyone. I am Dr. Sudhir Palsania, Consultant Medical Oncologist, LV Hospital, Jaipur. I invite Dr. Piyush Bajpayee, sir, HOD and Consultant Medical Oncology, Manipal Hospital, for the choosing the +1 immunotherapy combinations in non-small cell lung cancers.
Yeah, good evening to all, and I hope my slides are visible over there.
Yes, sir. Just make it full screen, sir. Yeah, perfectly fine, sir.
Yeah, I thank the organizers for giving me this opportunity. So, choosing +1 in immunotherapy, and that's what now we have started practicing. Of course, immunotherapy is very much in metastatic NSCLC, and actually it is taking the lead, coming by leapfrogging rather into the early setting also. Today, I would be just focusing on the metastatic NSCLC. And what we have seen is, as compared to the control arm, chemotherapy showed the benefit, as you can see in the red curve. But the benefit was not very, durable, and the survival was just 5% at the end of 5 years. So we did not see many survivors at the end of 5 years. But then entered the immunotherapy, and what we call, you can see the tail of the curve. That was the plateauing thing which was there, but it was not very gratifying. It was like 20%, 23%, and you see a very steep fall initially. So that has always been a concern with immunotherapy. And so what was expected with the going beyond immunotherapy is like, if you combine something and you need to actually bring these two aspects, make these two aspects better. You need to actually decrease the slope of the initial curve and also make it, durable in the last part. So that is what is expected. And this has been the evolution. And it's, of course, still evolving. So this is just revisiting the past again. And this is a meta-analysis in 2008, where we see that against the best supportive care, just touching at 10%, below 10% at 24 months. So that's what it was, that 5% at the end of 5 years with chemotherapy and supportive care alone. And Keynote-1, the phase 1 study, the phase 1B arm of lung cancer, which actually looked into it. This was presented in ASCO way back, and then the 5-year overall survival data was presented. And what was appreciated over here was that the tail of the curve was pretty, stagnating over there. Plateau was there, and there was a heartening thing to see a nearly fourth patient who were treatment naive, and these patients were actually, still responding to immunotherapy. There was a durable response. For heavily pretreated also, that is those who had received previous treatment, 15% were actually, doing well at the end of 5 years. So this, what it did actually, it was a phase 1 study. It had a durable response, immunotherapy, and so became a very appreciated trial. And it, of course, established PD-L1 as a biomarker. In fact, the presenter, Dr. Giran, was actually an expert in biomarker analysis. So talking about immunotherapy only in the upfront setting, and this was a bit of a shocker when nivolumab trial was presented. This came in NEJM publication, was presented in 2018 ESMO. And this was a bit upsetting where it was not making a dent beyond chemotherapy survivals. The curves were actually sticking. What we learned was probably if you look at the tumor mutation burden properly, then you could make the difference. But otherwise, PD-L1 above 5% population was taken, and the curves were actually sticking to each other. So probably you need to use immunotherapy in a more targeted way, and PD-L1 was one thing which the pembrolizumab team was looking at, and Keynote 024 actually was this particular study design where it was very handpicked of patients who were TPS above 50%. So that was important, and they chose their patient wisely over there. And they pitched against platinum doublet chemotherapy 4 to 6 cycles, gave it for nearly 2 years. And the primary endpoint, as we could see, the PFS, the secondary overall survival. So what actually we saw with the Keynote 024 and 5-year overall survival rate was again impressive over there, like the Keynote 1. And actually 31% versus 16.3% patients at the end of 5 years. And that's very good when we see the progress. So you could probably go away with chemotherapy in this particular subgroup of patients who were actually having TPS score of more than 50%, DACO22C3. That partner was important, the biomarker partner was important. And of course, it was a better tolerated drug, better safety profile as compared to chemotherapy. Atezom, the trial was a sort of presented late, and but it was again similar and encouraging data with the PD-L1 inhibitor, again it is over there. So in the TC3 or IC3 expression, again, which is equivalent to the tumor cell PD-L1 more than 50% expression, one could see that pitched against chemotherapy, it was showing the benefit in terms of overall survival. But the disappointment again continued, with those who were not good PD-L1 expressors. There were those who were intermediate to poor expressors. Outcomes weren't great. So it was just a quarter of patients that were benefiting. And one had to think twice what to do about the patients who are less than 50%. And then came, these trials were, though showing Keynote 4.2 was showing that the benefit would be there, but it was sort of the initial fall in or progression was very fast, and likewise in IMPAR 110, where the TC1 or 2 was there, or IC1 or 2 was there. So also the realization that PD-L1 alone might not be great marker, even if it is the more than 50%, and you could have, if the TMB is less, probably you would not have those curves what you see if the TMB is also high. So there were other things also, and there was gender also, and that's in another PD-1 drug study where you had, and of course there were other factors, that the burden of disease, very heavy burden of disease. Could you just depend on PD-L1 above 50% and give immunotherapy alone? So there were other factors as well. So you need to go beyond the immunotherapy alone. And that's what came the idea that why don't you combine chemotherapy and immunotherapy? And so Keynote 189 was one particular classical trial in adenocarcinoma subset. And here, what was seen eventually was that the overall survival was, met in this in the intention to treat population, though the major driver again here was PD-L1 subset of population, which was more than 50%. But nonetheless, PD-L1 1 to 49% and less than 1% was also showing the benefit over there. So we could see clearly that the overall survival was nearly 21 months versus 12 months in 1 to 49% and 17.2 months versus 10.2 months in PD-L1 less than 1%. So the efficacy benefit was present in all the subsets. Even if you look at the less than 1%, there was efficacy benefit present if you added chemotherapy to immunotherapy. What about squamous? Squamous is otherwise a very aggressive histology as compared to adeno, but here Keynote 407 was also showing that particular benefit translating over there, and overall survival in intention to treat population was met. And all the subsets, even the less than 1% of PD-L1 expressors were actually benefiting over there. So in this particular scenario where you use chemo-immuno combination, what was realized that in these exploratory analysis of 189 and 407, you might not really require to look at TMB. So if in case you do not check your patient for TMB, you might not miss on something. You can safely combine chemotherapy and immunotherapy when you do not when you are missing on TMB data. So talking about IMPAR 130, again a similar design of study where nab-paclitaxel carboplatin was taken, a steroid-sparing agent, along with atezolizumab, with atezo being given in maintenance, and crossover from arm A to arm B to arm A was initially permitted. However, it was restricted later in the time, and the only thing was that you see that atezo being used in the maintenance arm. The criticism of the trial was why not the pemetrexed arm was there. So that's one particular thing, because pemetrexed has been one of the favorite therapies in adenocarcinoma. Why was only nab-paclitaxel used? Probably because of the steroid sparing effect. Atezo was there, so atezo was there in the maintenance till progressive disease. Here again, PD-L1 was checked, and what was found that overall survival significantly improved with the addition of atezo to this combination, and the 2-year follow-up data, it did show that 39.6% versus 30% benefit. So overall survival was also significantly improved in the intention to treat population. One particular subset, if we look at it over here, and although most of the subsets are benefiting, but if we look at the liver metastasis, basically, this particular subset, liver metastasis enrollment, is not really benefiting over here. So something more needs to be done if the burden of disease is heavy. So this particular combination actually did not impress in the squamous histology. And despite nab-paclitaxel being used, the curves weren't separating out impressively. So pembro chemo was a clear edge over there as per Keynote 407. IMPAR 131 was not a suitable combination in squamous cell histology. Well, chemotherapy and bevacizumab as per IMPAR 150. So it's and of course immunotherapy. So this was something adding 4 drugs, and here again the key endpoint was met, and of course the trial is famous for this particular subset of nearly 20% of patients which had actually progressed EGFR therapy, primarily EGFR therapy, and there was benefit in these patients as well. Talking about the IO combination, and This was in the last ASCO, a 4-year update of the Checkmate 227 study presented, nivolumab, ipilimumab, a chemotherapeutic free arm versus chemotherapy as first-line treatment in NSCLC. And the 4-year-old overall survival in population with the PDL1 above 1% was actually met, both in adeno as well as in the squamous histology. If you look at PDL1 above 50%, impressive, survival rate of nearly 37% at 48 months. So that was found as compared to chemotherapy, just 20% over there. In less than 1%, this was working. So if the PDL1 was less than 1%, again, this was working again with a survival rate of nearly 24% at 48 months compared to chemotherapy, which was just showing 10%. And look at the initial part of the curve. You see that the curves were still sticking over there. There wasn't much of separation till you see 12 months down the line, once the curves actually start separating out, the red line starts going up. So probably there was this thought that, you need to separate out those 3 curves in the initial part. And therefore, the addition of chemotherapy would help. So just talking about this particular trial, the safety analysis, well, it was not that it was though it was chemotherapy-free regimen, but it was actually having some serious grade 3-4 toxicities, immunotoxicities, which nearly led to 12% of patients stopping the treatment. Well, everything combines, everything combined to ipilimumab would not work like that. So here you have Keynote 598 study, and it's not actually working over there. So the partner of IPI was probably important, and Nivo remains the partner over there as per the previous study. Talking about this particular study where this addition of 2 cycles of chemotherapy was looked into, and versus 4 cycles of chemotherapy, Checkmate and 9LA. And here the EP was 1 mg per kg once in 6 weeks, Nivo of 360 mg once in 3 weeks with chemo, 2 cycles, only 2 cycles, 3 weekly cycles were given versus 3 weekly, 4 cycles of chemotherapy. So this was given, Nivo was continued thereafter until disease progression, unacceptable toxicity, or for 2 years for immunotherapy. So 2-year update, overall survival in all randomized patients. We saw that at 2 years, 38% was the overall survival rate versus 26% in the chemotherapy arm, with a median overall survival of 15.8 versus 11 months. So it was a positive trial with the PDL1 less than 1% population. Again, the efficacy outcomes were maintained, and we could see the curve clearly separating for OS, PFS, and duration of response, and a good plateau at the tail of the curve is being seen. Now, this particular subgroup, if you see in the forest plot analysis, if we see that liver metastasis, again, this liver metastasis over here is having some benefit, as if we saw in the atezo chemo arm, where the benefit was not so great, but here these patients derive benefit. Another important subset, if we look, is CNS metastasis, and you see that there is a clear benefit in these patients. The survival advantage is being passed on in these patients as well. Of course, it comes with its own set of side effects, though the chemotherapy is less, but then grade 3-4 side effects are more immune related, and some serious side effects were nearly 26%. So that was important. Median duration of therapy, nearly 6 months for the combination versus 2 months with the chemotherapy. In the Nivo-Ipi chemo arm, patients received a median of 9 doses of Nivo and 4 doses of Ipi. 93% of patients received 2 cycles of chemo. So what to do once you fail on IO combination? And there is some news from ASCO, And this is a phase 2 study, lung map, non-match sub-study S1800A. And here, there is pembrolizumab given for nearly 2 years, and initially coupled with the ramucirumab given 3 weekly again, pitched against investigator's choice standard of care, which was either docetaxel, ramucirumab, or other chemotherapy. So here, the primary endpoint was overall survival. This was a phase 2 trial. So median overall survival was found to be statistically significant in advantage of the ramucirumab and pembro arm versus standard of care 11.6 months, 14.5 versus 11.6 months, with a hazard ratio of 0.69. So the conclusion of this trial was that in patients who have been treated with immunochemo arm, and if you start this particular therapy combination, pembro ramucirumab, you would find the curves going better than the standard of care. So that is an important study, I think so, and would probably translate into practice. Something more in the pipeline. Well, we talk about KRAS co-mutations being present, STK11 and KEAP1, where we expect that the immune checkpoint inhibitors will not act very nicely. So once these inhibitors to these are found, and there are now sotorasib is there, where sotorasib is being combined with immunotherapy, to see whether it would work over there. So this is important. So this is from one of the experts, Dr. Chetali Nangia, and she says that an individual who isn't chemotherapy amenable or who has chemosensitivity, then that's the one she would consider chemotherapy-free IO combination. If there is a bulky disease and symptomatic painful, she would go with chemo-IO combination. At the same time, if there is low volume oligometastatic disease, PD-L1 is high, then a single agent IO combination, IO drug. If there is squamous histology and PD-L1 is low or less than 1%, then ipilimumab or nivolumab combination, and especially in young individuals. For a patient with PD-L1 strata of 1 to 49%, a combination approach, whether that's chemotherapy plus PD-L1 inhibitor, chemotherapy PD-L1 inhibitor, angiogenic inhibitor, or CTLA4 inhibitor makes sense. So in a nutshell, these factors are important to be looked into, tumor factors as well as patient factors, before we look at combination. And these are the approved trials currently in the first line setting. Thank you.
Thank you so much, sir, for this wonderful presentation. Now I invite Dr. Vamsi Krishna, sir, Director and Head Medical Oncology, Hematology Institute of Oncology, AIG Hospital, Hyderabad, for a talk on Amivantamab and Lazatinib in patients with EGFR mutant non-small cell lung cancer after progression on osimertinib and platinum-based chemotherapy. Updated results from caseless 2 study.
Sir, hello. Dr. Sudhi, sir, he's just joining in minutes, and we are also requesting Dr. Shyam Agarwal to join. I think we have to wait for a minute, sir.
Yes.
Yeah. Dr. Sudhi, sir, Hello, Dr. Sudhir. Dr.
Yeah.
Vamshi is joining in a minute. The moment he joins, you can introduce him again and then we start the
Yeah,
session.
sure. Sir, I invite Dr. Vamshi Krishna, sir, Director and Head Medical Oncology and Hematology Institute of Oncology, AIG Hospital, Hyderabad, for a talk of Amivantamab and Lazatinib in patients with EGFR mutant NSCLC after progression on osimertinib and platinum-based chemotherapy. They are the updated results from the Chrysalis 2 study. Over to you, sir.
Thank you and good evening. I hope I'm not too late because my topic was actually scheduled for 15 minutes from now. But anyway, Tarun, if you can start sharing the slides for me, please, then I can start the presentation. So what I will be doing is presenting this abstract that had actually come from the ASCO this year. Tarun, is someone sharing the slides or should I open them?
Sir, we don't have your slides.
Okay, done. I am just going to open it in a second. Just give me a second. So what I am be talking about is about this Amivantamab and the Lazatinib combination. Now, Amivantamab is a drug that has been discussed over some times in the last couple of years. Is a EGFR exon 20 and as an drug which is used after osimertinib. Now, this situation today, what I'll be presenting is the combination of Amivantamab and Lazatinib in patients with EGFR mutant NSCLC after progression on osimertinib and platinum chemotherapy. These are somewhat updated results from the Chrysalis 2 study. This was presented by Catherine Shu at the 2022 ASCO meeting. Now, as we keep going with more and more drugs, the names are becoming more and more difficult to pronounce for everybody. So apologies in advance if I am pronouncing it wrong throughout any time. So what is Amivantamab? Now, Amivantamab is an EGFR MET bispecific antibody along with immune cell-directed therapy. Lazatinib, on the other side, is a highly selective, brain-penetrant, third-generation EGFR TKI, which is active in EGFR, T790, and CNS disease. Now, the rationale behind this drug is that if you have the targeting of both the extracellular and catalytic EGFR domains, you probably have better anti-tumor study. There was one small study which showed that patients who progressed on osimertinib but chemo naive, the overall response rate was 36%. So this combination is now being used among patients who have failed osimertinib and platinum. So basically, the Chrysalis 2 is a dose expansion cohort. They are having multiple cohorts in this. A is exon EGFR del 19 or L858R post OSI and platinum based. Cohort B is exon 20 insertion post standard of care and platinum based chemotherapy. Whether the standard of care in this is TDXD or is it something else, we don't really know. Cohort C is the uncommon EGFR mutants and again treatment naive or post chemotherapy. The cohort is again exon 19 and L858R, but chemo naive. So the endpoints, this is not a very randomized trial, so you are not going to get the overall survival as one of the primary endpoints. You do have ORR as the primary endpoint, duration of response, clinical benefit rate, PFS, and OS as other results. So the study, what was presented in the ASCO this year, showed the updated efficacy and safety results. Now, when you look at the patients, around 41% had brain metastasis at baseline. Treated were around 22, untreated 19, so roughly half. Median number of prior chemo lines of therapy were around 3, mostly 2 to 3, but a significant population of 28% were more than 4. Prior regimens, the most common ones which we use, that's either OSI followed by a platinum-based chemo, or a first and second generation TKI followed by OSI followed by platinum, or heavily pretreated. And again, pretty much standardly divided as we would probably see in our clinical practice as well. The endpoint, as I said, was ORR. Now, the blinded review showed the ORR to be around 33% with a median duration of response of 9.6. CR was 1, partial response was 32. Again, stable disease around 43. The clinical benefit rate is around 57%. Kind of confused as to where they got this clinical benefit rate from, because this should have both durable, it should include normally stable disease all, but what they have done is they've included patients who had a stable disease of at least 11 weeks duration. I am not sure why they had to do these two things, probably because the stable disease was evaluated early and then later on they found that they were progressing. So be as it may, the clinical benefit rate as per their definition is 57%. The investigator assessed ORR is 28% and duration of response is actually lower. Median follow-up was 10 months, median PFS of 5 months, which is quite okay for such a heavily treated population. Median OS 14.8 months. Again, quite a reasonable amount. The subset analysis did not really show much, but again, with the number of patients of 162, I don't really expect it to show much differences. Most interestingly, even if patients had taken osimertinib as first line or as second line or heavily pretreated, it did show a benefit. Looking at the anti-tumor response and ORR, again, the different colors indicate the previous treatments given. And patients who had taken OSI, the ORR was 21%. Those who had taken chemotherapy, osimertinib and EGFR was 36%. And heavily pretreated was surprisingly the maximum, that is 39%. Again, we don't know whether it really means something. This is more of a hypothesis generating. You can't really make much out of these numbers. The durable disease control was seen in a lot of patients. One example which they gave, they did allow stable treated and untreated brain metastasis patients. So among the 66 patients who had baseline brain lesions, 30 untreated, 27 at least had one scan. CNS lesion assessment, complete clearance was seen in 26%. Present, that is something like a partial response probably, was seen in 74%. Interestingly, nobody had an unequivocal progression. So that is important because most patients seem to have some response to it. 5 patients did have documented non-target progression, which could be a leptomeningeal or something else. So this is just one example to show. They had a 52-year-old male who had already got radiated with surge, gamma knife, afatinib, chemo, osimertinib, had a new CNS lesion, then had a complete response by week 6, which was maintained for 1 year. So that's how good probably the drugs are. Safety profile, more or less the standard ones, mostly grade 1 and 2. You do have rash, you do have some hypoalbuminemia and edema. Again, I have not personally used these drugs, but those who have used Amivantamab especially seem to have had, they're saying it is having some side effects. It's not as simple as it sounds. Dose interruptions, reductions, and discontinuations were seen in 35, 9, and 7%. Most important for this is always the discontinuation and reduction, which is around 9 and 7, which is fairly reasonable. Pneumonitis ILD was the most important side effect, 4% grade 3 and above. Rash-related AEs, 10% grade 3. Again, this is something that we have seen. I'm curious about this rash-related AEs specifically because Amivantamab is supposed to have a kind of a ichthyosis kind of reaction as well. They have not specified. They have given this whole list of what all were there: dermatitis acneiforme, drug eruptions, erythema multiforme, and so on. But rashes are seen with this drug. That's what, at least what I have gathered from other people. So to conclude, Amivantamab and Lazatinib does demonstrate a durable anti-tumor activity in patients progressing on both osimertinib and platinum. Comparable to previous groups, what that suggests is that, well, if you give chemo, it does not really impact their activity. So it doesn't improve the activity, but it does not impact their activity as well. Safety profile is consistent, no new safety profiles. So in a pre-treated, heavily treated population, probably this is a drug combination that can be used. Again, the remaining Chrysalis 2 are continuing. You have 2 new studies, both in the front line and as well as with chemo in post-OSI. So again, I think it's a good drug, both of them, and we are going to see more and more papers in the next couple of years as well. So thank you, and that was my presentation.
Thank you, sir. This is new insight in the treatment. Now I call Dr. Shyam Agarwal, sir, Director Medical Oncology, SGRS Delhi, for capmatinib, unlocking the unmet need of MET exon 14, skipping the NSCLC. Over to Shyam Agarwal, sir.
So thank you, Dr. Sudhir, and all the organizers, Dr. J.B. Sharma, for giving me this opportunity. So this session is focused on the role of capmatinib in patients with MET exon 14 skipping mutation in patients with non-small cell lung cancer. So let's go to the study, please. Next slide. So you can see here that nearly 3% of the patients of non-small cell lung cancer will have the MET exon 14 skipping mutation. And I think this particular mutation is common in approximately 25% of sarcomatoid carcinomas. So I think we should keep that in mind so as to, not miss those patients for performing the test for MET exon 14 skipping mutation. And they're linked to early stage diagnosis and older age. And this basically, is a splice site mutation in the MET leading to exon 14 skipping result in the MET juxta membrane gain of function alterations. Next slide. So it's not a small number, 3%, as you can see, similar to Ross maybe. And once a patient has MET exon 14 mutation, so it is associated with bad outcome, that is the worse survival. As you can see here, OS for MET is lower as compared to MET negative mutation. And similarly, the DFS is also, inferior for patients who have this MET mutation. Next slide. So I think like the targeted, patients with a target in their tumor, and including the MET exon 14, they don't respond well to immunotherapy. Possibly they are addicted to this particular mutation, and therefore they don't harbor those, multiple gene alterations, etc. And therefore one should not think of using, immunotherapy, at least in the beginning, because the overall response rates are poor. The PFS is 1.9 months. So it's not a, it's if you have MET exon 14, so don't use immunotherapy in the first line at least. Next slide. Okay, so if you have the MET inhibitor, such as a drug like Crizotinib or Lazatinib or Checkmate, so I mean you have a better outcome in terms of overall survival. That is 24.6 months. Patients who received a MET TKI and patients who never received a TKI, you can see the overall survival is 8.1 months, indicating that these are like phase 2 studies where you find that the MET inhibitors are able to target the exon mutation and help control the progress or progression of cancer in the subgroup. Next slide. So Checkmate is a selective MET inhibitor, and as we all know, the drug is sort of available to us in our practice. So it has more than 10,000-fold selectivity for MET receptor kinase when assessed against a panel of 55 other human kinases. And this is also very, very important that the drug crosses the blood-brain barrier, showing preliminary brain activity. And as you see here, compared with other agents, Checkmate is the most potent inhibitor against MET exon 14, where the IC50 is 0.6 for Checkmate and much higher for other drugs like Tepotinib or Crizotinib. So this is the study, which is focused on MET alterations, which is Geometry Mono 1, and basically 2 cohorts. One is cohort 4, where pre-treated patients with MET exon 14, regardless of the MET, gene copy number, there are 69 patients, I'm sorry. And the cohort 5 had, again, B patients, MET exon 14, regardless of, the copy number, again, 28 patients there. And then, of course, they had the other cohorts like MET exon 14, regardless of MET GCN. So these are patients who are treatment naive in cohort 5, and cohort 4 are patients who were pre-treated. So that is the difference between cohort 4 and cohort 5B basically. And these had to be, EGFR ALK negative and good performance status. So next slide. And they were treated with Checkmate, a dose of 400 milligram once a day. Can I go to the previous slide, please? Yeah, twice a day. So 400 milligram Checkmate, twice a day. I'm sorry. Next slide. So the idea was to, look at the primary objective was to demonstrate anti-tumor activity by ORR, and the secondary, key secondary was the duration of response. And the other secondary points were overall survival, safety, the PK studies, and the time to response and the disease control rate. Next slide. So, as I said, the study focus, these cohort 4 and 5B, these are pre-treated and these are treatment naive, 69 and 28 patients. So, as you can see, not only adenocarcinoma, but there were patients of squamous cell carcinoma, 8.7%, and around 80% were adenocarcinoma. And there were baseline brain metastasis in around 15% of the patients. And the gene copy number for MET amplification, you can see less than 4 to 6, or less than 10 was seen in almost 60% of 2/3 of the patients. More than 10 was only like 15, 16%. And they were ex-smokers or non-smokers, never smokers, mostly. Next slide. So in cohort 4, who had the pre-treatment, so the number of cycles or the, first line, second line mainly were 88%. First line and second line was 72. So 2 lines of therapy, as you can see here, prior therapy lines. And some patients had received immunotherapy also in the second line and some in the first line. So small numbers, but that is the representation here. Next slide. So now for patients who were pre-treated in cohort 4, so as you can see, the CR rate, PR rate, and the overall response rate is to the tune of 40 to 43%, and the disease control rate of nearly 77%. So which is quite impressive, because these patients were either 1 line or 2 line pre-treated with chemo or a platinum-based treatment. Next slide. And patients who were treatment naive, although they were small in number, 28 to 29 patients, you see 68%, and the investigator was 60%, but the disease control rate was nearly, more than 95%. Next. So I think these are the plots here, which show you the the tumor shrinkage as per the the criteria here. So cohort 4 pre-treated, cohort 5B better, as because these were untreated. Cohort 5B, deep responses were observed. Next slide. So these are the duration of response. So median duration of response for cohort 4 was 9.7 months, and longer, as you can expect, because they were naive. In cohort 5B was 12.6 months. So, which is something like, I guess, EGFR inhibitors when you are looking at first generation or at the most second generation. Next slide. And the progression-free survival 5.42 in pre-treated and 12.42 in the untreated patients. Next. So this is the swimmer plots for responders. So as you can see, there were rapid and durable responses in both the cohorts. And the first tumor evaluation, the responses were seen in 82% in cohort 4 and 68% in cohort 5B. So, you would expect to see a response within 8 weeks when you're doing a first, imaging in these patients. Next slide. In majority of the patients. So very few patients had brain metastasis, 13 evaluable patients brain metastasis at baseline, and 54% patients had an intracranial response. So which is quite encouraging, because as I said, the drug does cross the blood-brain barrier. And 12 out of 13 had intracranial disease control, whereas the response was seen in more than 50%. And they were complete responses as well in some of the lesions observed when you used Checkmate. Next slide. So this is the result of the Checkmate was seen irrespective or independent of type of MET mutation, whether it was a SNV or insertion or deletion indel, leading to MET exon 14 skipping mutation, or irrespective or independent of co-occurrence of MET amplification. So you can see whether it is FISH high or FISH medium, whether there is SNV or MET amplification or MET insertion or deletion. You are seeing kind of responses across all subtypes of MET mutation, and irrespective of what was the degree of MET amplification. Although, as I admitted, the number of patients are small, 69 and 28. So maybe a larger study could, figure out more about this, outcome. Next, please. Okay, so these are the updated results from the Geometry Mono 1 study. And so I think the next slide, Capmatinib 400 milligram twice a day. So this is basically, consolidating on the response rate, 66% and 98% disease control in cohort 5B. And there was this cohort 7, which again, showed 32 patients who were untreated, 66% and almost 100% disease control rate. So this is these are early consolidation data, kind of confirming the results of cohort 5B. Next slide. So 51 and 40% response rate for patients in second and third line, respectively. So this is again cohort 4 and cohort 6, which had another 31 patients. So 51% overall response rate and almost 91% disease control rate in cohort 6, who were second line or third line treated. Next. So majority of patients experienced a tumor response at first evaluation, as I said, 60 to 80% after initiating Capmatinib, and the durability of response does sort of depend on whether the patient is naive, where you can see the PFS of 12.4 months or in the first line, but when you go down to second line, third line, then it is 5 to 7 months. And the duration of response is almost again, 12.6 months versus 8 to 9 months in pre-treated patients. And so I think this is the summary of what you are getting with Capmatinib in patients who are either pre-treated or patients who are being given Capmatinib in the first line. Next slide. So this is the overall survival here. So as you can see, 20.8 months in untreated patients in the first line, and almost 14 months in second and third line. So which is impressive, in the second line, but certainly you see the curves are dropping, which means you need to do more to sort of help these patients. Next.
Oh, sir, brilliant presentation, but you need to conclude, sir.
Yeah,
Sorry to interrupt.
Yeah. So the drug is well tolerated. As you can see, the number of side effects in the edema, nausea, vomiting is, less than 5%. Next slide. So this is the last slide, I think, to conclude, which is summing up that in the first line, you expect a response rate of almost 65%, and and a disease control rate of nearly 100%. In pre-treated, response rate of 51%, and a good disease control rate, 20 months versus 13.6 months. The drug is very well tolerated. So you must, not only in adeno, but also in squamous, mostly ex-smokers or non-smokers. But then sarcomatoid carcinoma is another important thing to remember. So with this, I thank the organizers for giving me this opportunity.
Thank you so much, sir. Now I invite Dr. Akhil Kapoor, Assistant Professor Medical Oncology, Tata Memorial Hospital, Varanasi, for the talk on what information will help improve our treatment decisions in EGFR positive advanced NSCLC. Over to Dr. Akhil, sir.
Thank you for inviting me and this talk. So definitely we have seen significant work in the space of EGFR mutant lung cancer. In fact, we know the EGFR is the poster boy for lung cancer or overall. So what needs to be understood that this space has actually worked really fast, and from last 5 to 7 years we are now spoiled for choices. So that is a good thing. And but when there are multiple choices, we need to find the way and the best possible groups in which drug is effective. So let's take on the summary and a case. we'll see the case in detail and we'll have some discussion as well. So we want to understand basically what information will help us to improve our treatment decision in EGFR mutant advanced non-small cell lung cancer, relaying the relay. Next slide, please. So these are my disclosures. Slides have been contracted by Lily. So this is a 44-year lady who present. He is a premenopausal with hypothyroid. She doesn't have any other comorbidities. So she's a young lady with the premenopausal stage, and she presented with pain and breathlessness from last 7 to 10 days. At presentation, she was having performance status of 3 with no supraclav nodes, no icterus. There's a DVT. So DVT was identified due to the pain in the calf muscles, and Doppler clearly showed thrombus, and she was started on injection Clexane. Next slide. Later on, when we did a scan, a PET-CT showed a big mass in the right lower lobe. There was significant collapse. There was huge effusion in the right side, and also we can see there were a significant amount of lytic bony lesion at the sternum and also left acetobulum. So that was clear that this disease is mostly a lung cancer with multiple sites of metastasis. And biopsy was performed from the pleura, and it was found to be TTF1 positive adenocarcinoma of pulmonary origin. Next slide, please. So as I told, the patient was performance status 3, having significant effusions and DVT. So she was admitted for the supportive care from the baseline, and D-dimer was 5138. Pulmonary angiogram also confirmed thrombus in the lungs. So not only thrombus in the DVT in the calf muscles, there was a thrombus which has gone to lungs as well. So that means definitely there was significant disease burden. You can see an X-ray sciogram image. You can clearly see nearly half of the lung, more than half of the lung is having effusion as well. Next slide, please. So the patient had undergone ICD insertion, and we could see that there is significant consolidation as well. And their MRI brain was also done to confirm the status of the brain. There was no brain mets, thankfully. And the patient had right pneumothorax as a composite. This is post ICD insertion, and this is understandable. Post ICD insertion, there will be some amount of air along with the fluids, and this was the case status. Next slide, please. So to understand what further testing methodologies are preferred in the clinic at the diagnosis of metastatic cancer, whether we should wait for further molecular reports or initiate some form of the treatment. That is an important question in our mind, which we want to understand. But when we see a patient with performance status 3 and huge disease burden, we understand definitely this patient needs to be started on some of a form of treatment. Otherwise, what might happen, the patient might progress in a very short time and can become non-salvageable. So that is an important point which we always keep in the mind in the routine practice. What we do, we start chemotherapy in most of these patients, but we do not start immunotherapy. We all know immunotherapy does not provide benefit, and also it might lead to some significant increased toxicities in patients of EGFR or mutant. Also, we have just seen data from the MET also. These patients also do not respond well to. We started chemotherapy for this patient. Next slide, please. And this patient was initiated on pemetrexed carboplatin, which is the usual standard most tolerated regimen in such scenario. The patient had received 2 cycles, and the patient had the patient's tissue was sent for NGS as well at the baseline itself. The patient tolerated chemotherapy well with minimal complications and had significant clinical benefit in this time. We utilize this time for adequate management of the lung infections and DVT as well. So thankfully, this was possible while the patient was admitted. Next slide, please. We got a mutation in NGS. You can see it was EGFR exon 21 mutation with VAF of 32%. So this is a good variant allele frequency that clears any doubt. If VAF is low, we become somewhat doubtful, especially if VAF is more than 5% in the tissue, we take it very seriously. Also, there was associated some other mutations, but One mutation was P53. P53 is commonly seen in patients with EGFR, but these patients, we know these patients are having somewhat poorer responses to EGFR directed treatment. A RID1A mutation was there. PDL1 was 50%. This report came as very early. PDL1 50%. But we waited for the report and didn't start the patient on the immunotherapy, as I've just highlighted before. D-dimer had come down in the meantime. You can see it was more than 3,000. It has come down to 1,700 after about 6 weeks of the initiation of antithrombotic treatment. So definitely, we have the patient given the patient 2 cycles of pemetrexed carboplatin. The patient has received. Patient has improved in the performance status. EGFR exon 21 along with P53 and ARID1A mutations have been found in the NGS report. Next slide, please. Now, what to do? What we need to understand, as I discussed in my initiation introduction slides, whether all these mutations are similar, whether it's deletion 19 and L858 are similar. No, we know these behave differently. Whether we treat them differently, yes, there are options now to treat them differently. We'll look at some data as well, and we must be aware. And because we clearly know that deletion 19 responds well to the standard TKIs, be it the drugs like osimertinib or other drugs, but definitely L858R behaves differently. Prognostically, definitely it is a complete different ball game. So it is now time to tailor the treatment. And also with the NGS report, we were able to find some particular mutations which included P53 and ARID1, which help us to understand that this might not be responding very well to the standard EGFR TKI. So we'll see some data. Next slide. Yeah, so this patient was started on line. We'll see that as well. Standard EGFR kinase domain mutations, which we see in our practice. This is the usual 18, 19, 20, 21 mutations. Most common is 19. It comprises around 50%. Then exon 20 comprises around 3%. T790M is a part of this as well, 3% again. Exon 21 is again a significant burden, 41%. Then other mutations include the rare ones, that includes L861Q, G719S. So there are multiple other mutations, but exon 19, 21 and some amount of exon 20 are the most common mutations which are seen in the routine practice. This we are very well aware of. So a specific mutation identification is important because there are some mutations which are very sensitive, as I have just highlighted. There are some mutations which primary resistant mutations, for example, T790, we know that this will not respond to standard first or second generation EGFR TKI. And there is also a need to identify de novo and acquired resistance mutation with time point. When we have started already a patient on EGFR TKI, the NGS might help us to identify the mutations which are coming up, propping up in the tumor itself. Next slide. So this is a very well-known settings. This we have discussed, 19, 21, 20 and uncommon EGFR. Next slide. So what is to be seen here? If we see the data of indirect comparison in cases of exon 19, you can clearly see Gefitinib, Erlotinib, Afatinib all have work well, and hazard ratio is 0.59 with 0.3 border p-value of 0.019. So it is very clear that exon 19 patients do very well as compared to exon 21. This is the indirect comparison, and the hazard ratio of having exon 19 is itself 0.59 as compared to exon 21. So that becomes very important. And this is an indirect comparison meta-analysis from 1,380 plus patients from 6 different studies and utilizing first or second generation EGFR TKI. So next slide, please. So what is need to understand again, that significantly reduced risk of disease progression for exon 19 deletion versus L858R, as I have highlighted multiple times now. Next slide. So these are from the various 6 studies, including the recent CHOI study. And also exon 21 is known to harbor multiple concomitant mutations. Exon 19, usually it occurs in singlet, but exon 21, we clearly see the co-mutation rate with exon 21 is as high as 69%. Exon deletion 19, it is still there 40%, but it is close to 70% patients who are having multiple co-mutations with exon 21. That makes us very worried, because we know there are multiple co-mutations which reduces the response to EGFR TKI. If we see the PFS, yes, patients having concomitant mutations, the PFS drops from 17 months to just 6 months. So 1/3 PFS when patients are having compound mutations. Overall survival is also very different, 22 months versus not reached with concomitant and compound mutations. This is the data from Sun Yat-sen University, China. Next slide. So this is very understandable, and we need to look at the same. This is what we have looked. The difference is huge between exon 19 and exon 858R. Next slide. So tumor mutation burden is also higher in these patients. So what next treatment to be used? Now we have the options in exon 21 to use either erlotinib or gefitinib, afatinib or doxorubicin. Osimertinib is also an option. Ramucirumab plus erlotinib, chemo plus gefitinib is also an option. So what would be the best option depends on the clinical scenario. In this patient, what we choose, we'll see. Next slide, please. So the patient was actually started on ramucirumab plus erlotinib combination. We see this data of the first line EGFR TKI, where the various data has been seen. Single drug versus there is also data of afatinib versus PEMSIS. It has shown small PFS benefit over the first chemotherapy, definitely, but not shown any overall cell benefit. Also, there is a FLORA data which for osimertinib, it shows significant PFS benefit from 10 months versus 19 months. But what needs to be understood, if we see the subgroup analysis, the forest plot, exon 21 patients and patients are bang on the middle. So exon 21 patients do not seem to getting a significant benefit from using drug like osimertinib. That is an issue with the drug. Next slide, please. So this is the first line TKI combination, data from our own institute, TMH Mumbai. We saw that JEF plus chemo data. Yes, JEF plus chemo is a good option in patients who are unable to afford higher end treatments, higher third generation TKI or other TKIs. But this comes at the cost of increased toxicity. Therefore, it is not usually utilizable in all patients, but yes, selected fit patients, it can be considered. There's also some combination data of Japanese groups, which includes JEF plus chemo versus gefitinib, also erlo plus bevacizumab and erlo plus ramucirumab. The relay data, which is 450 patients, overall response rate was 76%, and PFS was 19.4 months versus 12 months. So a significant PFS benefit is clearly over the erlotinib alone with the relay data. Next slide. So if these are the sub data for the exon 21, definitely this is multiple other data. If you want to see, this is the FLORA data, 11 months. This is exon 19, 11 months versus 21 months. But if we see exon 21 for the same, it is 9.5 versus 14 months only. If we see the lung 3 data, it is you can clearly see it is 5.6 versus 13.8, but with the exon 21, again, it is coming down from 8 to 10 months only. So these are clearly a subgroup exon 21, which is not getting so much benefit. Even with dacometinib, it is 12.3 months only. So we need to be very clear that exon 21 is a different ballgame together, and these patients, the median PFS does not exceed 14 months with the available single agent EGFR TKI. That is why there is a need for some combination treatment. Next slide. So this is as I told, this is the treatment. Patient was started on ramucirumab 10 mg per kg 2 weekly doses plus erlotinib along with denosumab, and L-Clexin was shifted to apixaban because the patient was doing well and patient's thrombosis reduced. Next slide, please. The patient, you can see the images. This is the imaging. You can clearly see there's significant reduction in the tumor size, and you can clearly see the right lung, which was full of disease, has not significantly improved. You can see this is the baseline imaging, very huge disease burden. It has come down after 3 months, further reduction, and it is actually, you can see nearly 80% tumor has gone in the right lines. That becomes very exciting. And the patient is on continued erlotinib plus ramucirumab along with denosumab, and apixaban also being continued. Next slide. So this is the type of response we would like to see. Any role of immunotherapy in such patients? We have just seen some data. Subsequent treatment with immunotherapy does not help these patients much, but it can be considered in combination with the ABCP protocol. But let me very clear, we know that these patients will develop significant toxicities if patients who are osimertinib are shifted to immunotherapy. In the next line, or patients who are immunotherapy are initiated on osimertinib. So this is an important issue which should be kept in mind. So patients who have been treated with osimertinib within 3 months of immune checkpoint inhibitors, 24% developed severe grade 3, grade 4 immune-related adverse effects, while if OC is given before ICI, this is not the case. So this is an important point which should be kept in mind while using this drug. Next slide. Further data with increased use of NGS, definitely we see that concomitant mutations play a significant role in deciding the prognosis, and also they influence the treatment decisions. And this is becoming a way to pick the best possible treatment in our patients. Next slide. We'll see the data for RED1A mutations and other mutations as well. This is the data which I've already presented. Mutations who have been identified, multiple concomitant mutations with exon 21, they definitely reduce the PFS and OS in these patients. This is very clear, and 70% patients will have concomitant mutations. Next slide. So we have further data. This also we have presented reduced PFS and OS in exon 21 patients with the concomitant mutations, and overall EGFR mutations with concomitant mutations are doing poorly for our patients. So concomitant mutations are important to be checked actually. That is why we prefer to do NGS whenever feasible. I completely agree. NGS doing in every patient at the baseline might not be feasible due to cost constraints and multiple other constraints, but definitely if resources are available, I usually prefer to do send NGS in such patients, even in patients who have been detected to have EGFR mutation at the baseline, because this helps us to prognosticate and understand how frequent should be the imaging, what the time period of PFS is expected. These are important things which patients and patients' relatives ask us, and it helps us to give some idea of the same. Next slide, please. So this is presence of TP53 is a known mutation which reduces the significant PFS is reduced, and also potentially it is a useful clinical predictor of small cell transformation. If P53 mutation is becoming high, for example, we have done NGS as baseline, and later on we see P53 allele frequency has significantly increased, it might be a marker that it has undergone small cell transformation. This is also important, and this is needs to be understood. TP53 has a significant role in angiogenesis. So patients who are having TP53 mutation, angiogenesis takes an upper hand in such patients. And if we are able to use angiogenesis inhibitor in patients with TP53, it seems to be a very valid way of inhibiting these mutations. Next slide, please. So also in the relay trial, we see that prevalence of P53 mutation was at the baseline was 43%, and at time of disease progression, it was again 17%. It was similar in both the subgroups. So even patients who had group, we need to understand that it is not a single mutation, it is multiple mutations, and multiple coexisting mutations play an important role. Also, there is data for other mutations, and with this, I will summarize. In patients with exon 21, median PFS is yet to exceed 14.4 months, and with relay, we have the highest median PFS for exon 21 patients, reaching up to 19 months. Ramucirumab Lazatinib is a new treatment option, and that we are already employing it for our patients. And additional ramucirumab is associated with manageable toxicities in our patient groups as well. Personalized determination of optimal EGFR treatment remains the key, and it is a matter of shared decision making. Therefore, we try to utilize best possible diagnostic mechanisms as well for our patients. Next slide. So these are the key takeaways which I have listened. This is the package information. I would like to stop here. Thank you.
Thank you, Dr. Akhil. And I invite Dr.
Thank you.
Dr. Manish Sharma, sir, consultant and head of unit medical oncology, Rajiv Gandhi Cancer Institute, Delhi, for right choice first line management of ALK rearranged non-small cell lung cancer carcinoma and SCLC. Over to Dr. Manish Sharma.
Thank you, sir. I'm audible and my slides are visible.
Yes. Yes.
Good evening, all, and thank you for inviting me here. And it's a good academic feast. So I will be speaking on the first line management of ALK rearranged and SCLC. And in particularly, I will be talking about lorlatinib, what the Crown data has to say in this 2022, and how does the PFS and overall survival looks like in different kind of ALK inhibitors which we have today. So there are plenty of choices and we are spoiled. We have first generation ALK TKI, second generation ALK TKI, and third generation ALK TKI. Let's go through the various data which we have, and then in particularly we will be speaking about lorlatinib. So this is just an epidemiological information. And in 2018, there were 67,000 new cases of lung cancer in India, and by 2040, it is expected that this figure is going to be doubled at around 1.2 lakh in number. And this is how the lung cancer mortality looks like in India. 2018, around 63,000 mortalities with lung cancer. It is consistently going to increase, and in 2040, 20 years from now, looks like that we will have around more than 1.1 lakh mortality from lung cancer in India. And this is the EGFR genomics, what it's looked like today, and we have plenty of different targeted treatments available. Almost we have discovered driver mutations in 50% of them. And ALK, it has been detected in the frequency of 1.6% to 11.7%. And in general, what we see in our institute, it is to the tune of 7 to 10% by the help of IHC, which we do. And in NGS also, we tend to find at around 7 to 8%. So this is the targetable mutation which we are going to talk about. 2007, first ALK rearrangement was discovered, and just within 5 years of the discovery, that it is a targetable mutation, first generation crizotinib came into being, and then subsequently ceritinib, alectinib, brigatinib got approval for different indications, and all of them now we can use in the first line. And now we are talking about third generation ALK TKI, which is lorlatinib, 2019, and now in 2022 we have some PFS data about it, and we will be discussing the Crown trial. So 3 to 5% of all patients are ALK rearranged, and most commonly they are seen in younger age, never smoker or light smoker, adenocarcinoma histology. 5 ALK TKI have been approved since 2011. First generation crizotinib, second generation ceritinib, alectinib, and brigatinib, and third generation lorlatinib. So what's the difference between first generation, second generation, and third generation? And this is the difference. So the amount of potency which the drug carries around ALK, third generation lorlatinib carries more potency. Then amount of activity in CNS, then it determines what kind of generation of ALK TKI it is. So lorlatinib has best in class potency against ALK. It has best in class potency in CNS. So this was the first drug which was approved, crizotinib versus chemotherapy, and profile 1014 showed the progression-free interval of progression-free survival of 10.9 months versus 7 months for chemotherapy. Overall responses being 74% versus 45% for chemotherapy. This is profile 1014 updated OS analysis, and this is final OS analysis in intent to treat population. You see that hazard ratio here is 0.76 for overall survival, and this hazard ratio is not statistically significant at the moment. It stands at 0.09 as reached versus 47.5 months for. This is Lazatinib versus chemotherapy SN4. Progression-free survival being doubled as compared to chemotherapy at 16.6 months, and the PFS at 18 months is 50% versus 23%. Overall response rate are 72% versus 26.7% for Lazatinib in SN4 with clinical trial. This is overall survival data. Overall survival still not reached. It is not recordable at the moment, and for chemotherapy it is 26.2 months for chemotherapy arm. If you see hazard ratio, it is 0.73, and you can see at the moment p-value is still not significant. This is ELECT study and the Alectinib versus Crizotinib. 34.8 months of PFS versus Crizotinib 10.9 months. So for Alectinib, in the ELECT study, the progression-free survival is 34.8 months, and Crizotinib it is 10.9 months. Hazard ratio, you can see that it has gone down to 0.43, which was initially 0.6 or 0.7 in Crizotinib alternative studies. It is now stands at 0.43 in this Alectinib versus Crizotinib study. This is overall survival, which is still immature, and the hazard ratio stands at around 0.67. So these are all the randomized clinical trials in first and second generation ALK-TKI, which we have at the moment. Profile 1014, Crizotinib versus chemotherapy, 10.9 months in the progression-free survival. SN4, Lazatinib versus chemotherapy, 16.6 months. ELECT trial, Alectinib versus Crizotinib, 34.8 months. And from ELTA trial, it is Brigatinib, which we have not discussed in detail. It is 24 months as a progression-free survival. So in all of these, if you see, the hazard ratio for progression-free survival is 0.45 here, 0.55 here in Lazatinib. In Alectinib, it is somewhere around 0.4. And for ELTA trial, it is around 0.49. So there is still plenty of things which we can do for ALK inhibitors, because most of our patients, they fail in CNS. So Lazatinib was rationally designed to meet this unmet need of ALK positive and SCLC progressing into the CNS for metastatic brain disease and the acquired resistance to ALK-TKI. So we know that whether we start the patient on first generation ALK-TKI, second generation, almost all of them, they will acquire resistance and then they will progress, which usually happens in all the metastatic disease. So Lazatinib was designed in a fashion that it works in those cases also which are resistant to ALK-TKI. So it effectively binds, it effectively penetrates CNS, it goes and gets retained into the CNS, it binds with the high affinity to most ALK-resistant mutations. This is Crown study. The key eligibility criteria were advanced NSCLC, ALK positive, with no prior systemic treatment should have been given for metastatic disease. ECOG performance status 0 to 2. Asymptomatic, treated or untreated CNS metastasis, they were permitted at the baseline, and more than one or equal to one extracranial measurable targeted lesion should have been present. The patients, they were randomized to Lazatinib 100 milligram Q daily versus Crizotinib, which is standard of care, 250 milligrams twice a day. The primary endpoint was progression-free survival by blinded independent committee review. Secondary endpoints were overall survival, progression-free survival, overall response rates, intracranial overall response rates, intracranial disease control rate, and overall survival along with the safety and quality of life measurement. So these were the baseline clinical characteristics. The median age group was 56. Most of the patients, they were Asian, and so 50% of the patients they were Asian, 50% of the patients they were whites. ECOG performance status 0 to 1, 50-50. Two patients they were ECOG performance status 2. 50% of the patients, they were never smoker, 37% patients, they were previously smoking, and 9% patients, they were current smoker. Brain metastasis was present in 26% patient here and 27% patient here in the crizotinib arm. And prior radiotherapy was given to almost equal number of patients in both the control arms, clinical. And this is the 36-month follow-up data, which we are going to present. At 36.7 months, the median follow-up for lorlatinib arm, the blinded independent committee review assessed that PFS remained longer with lorlatinib as compared to the crizotinib. So it was not reportable as yet, but in crizotinib arm, the PFS was 9.3 months. And if you see closely here, hazard ratio, it is 0.2. Hazard ratios in various other clinical trials which we discussed, like Alex trial or Profile 1014 or Alta trial, it was somewhere around 0.4. But here you can see that there is 73% risk reduction in hazard of progressing with the disease. At 24 months, 21.5% patient they were progression free, while 68% patient they were progression free in lorlatinib arm. And similarly, you can see here that closely 3.5 times more patients they were progression free at a 3-year landmark as compared to the crizotinib. Median duration of response still not reached in lorlatinib versus 9.6 months for crizotinib. And subset analysis has failed to identify any of the subgroup which is not benefited by crizotinib, whether male or female or previous smoker, non-smoker, extent of metastatic disease, presence of brain metastasis or not. You can clearly see here that in all of them, the hazard ratios, they are to the tune of 0.27, 0.24, 0.23, let's say. If you see the blinded independent PICR assessed PFS in patients with and without brain metastasis. So you can see here that it was with the brain metastasis, it was not reached versus 7.2 months of independent committee review PFS. And those patients without brain metastasis, it has still not reached versus 11 months for crizotinib arm. So these are the Kaplan-Meier curve. You can see those patients with baseline brain metastasis or those patients without baseline brain metastasis. So close to 60% patients here and 60 or 70% patients here, they are still on treatment without progression. This is time to intracranial progression for lorlatinib versus crizotinib. So if you see the straight line, so this is rarely seen in any of the oral TKI which we give to our patients. We are afraid of the progression in brain, and these were the patients who did not have any brain metastasis at presentation. And if you see, 37% patients had progressed at 3 years in brain in crizotinib arm versus 92% patients had still not progressed in crizotinib in the lorlatinib arm. And you can see here hazard ratio is 0.08. So rarely we see these kind of hazard ratios in oral TKI. This is BICR assessed intracranial time to progression in those patients who had baseline brain metastasis. So these patients, you can see at 3-year landmark time, it is 73% patients, they are still progression free in brain, even though they had brain metastasis, but none of the patients was progression free in crizotinib arm. And you can see here that hazard ratio is 0.10. So 90% of the responses in brain, which is clearly a good thing to have. Similarly, this is BICR assessed intracranial time to progression in patients without baseline brain metastasis. So these are to the tune of 99%. You never see these hazard ratio. These are unseen of in ALK positive tumors in ALK positive NSCLC, and hazard ratio here is 0.02. Median PFS being 30.8 months in crizotinib arm and not reached in lorlatinib arm. So this is the summary of overall and intracranial responses. Confirmed overall responses in intention to treat population 77%. Complete response is 2.7%. Median duration of response still not reached in lorlatinib arm. In those patients with any brain metastasis at baseline, confirmed intracranial overall responses, there was 64%. Complete IC responses, 59.5%. And duration of response not reached. And those patients who had any brain metastasis at baseline, this is intracranial confirmed responses in 83.3%, and intracranial complete response is 72.8%. 2%. And coming on to the side effects, so this is a newer drug. It has got some side effects which are not seen with other drugs. So you can see here the most common side effect which most of the patients will have. They are edema, hypercholesterolemia, hypertriglyceridemia. Few of the patients they will have weight gain, fatigue, and peripheral neuropathy. But if you see grade 3 incidence of grade 3 or grade 4 grade 4 side effects, so 20% of the patients they will have grade 3 or grade 4 hypercholesterolemia or hypertriglyceridemia, and 10% of the patients they will have grade 3 or grade 4 weight gain. They have some cognitive side effects also. Trial for Lazatinib at 18 months and 36 months. PFS 18 months follow 0.28. This is a hazard ratio 0.28, and as we are going deeper into the treatment, the hazard ratio has gone down to 0.27. Overall responses 76%, 77% maintained at 36 months. Complete intracranial responses with any brain metastasis at baseline 61% and 60% here again. 71%, 72% with at least one measurable brain metastasis. And how many patients did discontinue treatment? 7% of the patients had treatment discontinuation. So still 93% patients, they were on treatment at 18 months and 36 years. So this is the comparison of first-line ALK-TKI studies. Overall survival in Alex, Alta, and Crown study. Hazard ratio, if you see, 0.67, 0.92 here in Brigatinib, and 0.72 here in Lazatinib versus Crizotinib. So this is the summary of adverse events during phase 3 trial in first-line ALK-positive TKI. If you see the number of patients discontinuing drug, so it is least in Crown, that is 7%. If you see here, in Alex trial, it is 14%. In Alta trial, it is 13%, 9%, and 7%. And drug interruption or dose reduction seen in 21%, 24%, 38%, and 19%. So there is not the toxicity which had led to the more of dose reductions or dose interruptions or dose discontinuation, but the side effects is typical, that is hypercholesterolemia, hypertriglyceridemia, but you don't find plenty of liver dysfunctions which you find with Brigatinib or Alectinib. So Alectinib can have some transaminitis, increased bilirubin, which you don't frequently find in this Lazatinib. So this is the comparison of Lazatinib, Alectinib, and Brigatinib in ALK-TKI naive patients. This is a systematic network meta-analysis. So if you see here, as against Lazatinib versus Brigatinib or Lazatinib versus Alectinib, this network analysis is favoring Lazatinib, and hazard ratios are to the tune of 0.57 or 0.65. This is for those patients who are ALK inhibitor naive, and these are the ALK inhibitor naive and chemotherapy naive patients. Here also it is favoring Lazatinib. So in conclusion, in terms of PFS, our results indicate that Lazatinib was the best treatment choice for the patients with the ALK inhibitor naive or untreated patients. This is the real world data on Lazatinib, 41 patients.
Thank you so much, sir. Today's last presentation of this academic is Dr. Rajat sir, Senior Consultant Medical Oncology, Fortis Hospital, Noida, for the new advent for Atezolizumab in metastatic in NSCLC. Over to Dr. Rajat Bajaj.
Surbi, you need to run Dr. Rajat Bajaj slides if you have. Do you have slides backup? Surbi, do you have slides backup?
So,
for Rajat Bajaj.
Yeah.
Hello. Yes. Am I audible?
Yes, sir.
Yes, sir, you are audible, sir.
So we are sharing your slides.
Okay.
Just a minute, sir.
Okay. Yeah, please. So by the time the slides are getting arranged, I thank the organizers, Dr. Somani sir and his team for having me here. I thank Roche for giving me the opportunity. Uh, a very nice talk by Dr. Manish. Dr. Manish, are you there?
Yes.
Is Dr. Manish there? I think he's left. Dr. Vikas, are you there?
Rajat sir, slide confusion. And we don't have your slide. We didn't get the backup. Do you have the slide so that we can run, sir? Is it
I have mailed it to you. I have mailed it to you on your mail.
Okay, just a minute. Just a minute. Okay, sir. Yeah. Yeah, we have the slides, Surbi. If you can check your mail, I have just forwarded the slides to you, and then we can start.
Just give me 2 minutes, sir. You see the slides?
Yeah, Rajat sir, I think slides are in front of you in the screen. If you can just say next, that will be convenient, sir. Hello, Dr. Rajat, can you hear us, sir? Yep, please, sir. All yours, sir.
Hello.
Yeah, you can start, sir. You can see the slides. I mean, you can see the
Can I
screen.
start now?
Yes, sir. Please go ahead, sir. Go ahead, sir. Please go ahead.
Yes.
Oh, so, sir, your signals are very poor. Either
Yes, I can. Yes. Can I have the Yes, am I audible now?
Yes, sir.
Okay, yes. So again, I thank Roche for giving me the opportunities. This talk is going to be about the use of the molecule called Tecentriq or atezolizumab in the first line setting in metastatic non-small cell lung cancer. And the idea is to tell you about the background of NSCLC, how is the landscape of lung cancer treatment evolving, what is the study IM Power 110, all about 150, and then followed by 130, and then the conclusions. Next slide, please. So my august audience here knows that non-small cell lung cancer is a very common malignancy that we see in our daily practice. About 80 to 85 cancers, just about 15% are small cell. Age at presentation is less, 5 to 10 years less, and most of these patients, when they present to us, they are already in a stage 4 disease. So in the quest to look for the best treatment for a stage 4 lung cancer, we have come a long way in the last 10 to 15 years. Next slide.
Rajat sir, we lost you, sir. We can't hear you.
Hello, Surbi. Yes.
Yes, sir. Yes, sir.
Yeah. So, like I said, the evolving landscape of lung cancer treatment in the last 15 to 20 years, moving from chemotherapy to chemotherapy plus anti-angiogenic medications and from targeted therapy to now talking about immunotherapy in the first line, we have definitely come a long way in terms of improving the disease free survival and improving the overall survival of these patients of non-small cell lung cancer. Next slide. There is certainly an unmet need in the treatment of patients of NSCLC patients, especially where there is no actionable driver mutation. We do know, look at the Kaplan-Meier curves on the left side of the screen. It does tell us that if we have an actionable driver mutation, then the survival is definitely better than patients who do not have a targeted mutation as that. Also, the right side of the screen tells us that although we keep talking here and there about the driver mutations which have now come in non-small cell lung cancer in the last decade or so, the fact still remains that over 30% of these patients still will not have any targetable mutation. And what about these patients is what we are going to discuss in the next 10 minutes or so. Next slide. So, like I said, there are many phase 3 studies of this molecule called atezolizumab in the first line in the treatment of NSCLC. We're going to talk about 3 of them, which are all positive studies. So we have IMPAR 110, we have IMPAR 130, and then IMPAR 150. Next slide. We'll be talking about them one by one. First of all, talking about IMPAR 110, it's very important to note that this study was done in all histologies, that is squamous and non-squamous both, and it was about the use of atezo monotherapy versus a platinum agent that is either a cisplatin or a carboplatin, along with a histology specific molecule, be it pemetrexed for non-squamous or gemcitabine for squamous in the first line NSCLC setting. Next slide. So this is the trial schema that we're talking about. Stage 4 patients and PDL1 selected. EGFR ALK has to be negative. There were no mention of the other biomarkers, mind you, and the PDL1 IHC expression was segregated or stratified into low, intermediate, and high, which we'll see in a while. And they were randomized 1:1 to receive either atezo in the standard dose of 1200 milligram every 3 weeks, or it was a non-squamous or a squamous histology based treatment, which I just mentioned, PEM platinum or gem platinum. If it was PEM platinum, then pemetrexed maintenance also had to be there according to the Paramount study of NEJM 2014. And after that, the treatment had to change if there was a progression. Next slide. So what was seen was that if you look at the segregation of these patients into a low PDL1 expression or an intermediate or a high, there were about 30-35% patients who had a high PDL1 expression, which is called as TC3 or IC3. TC and IC is basically the tumor cutoff score and the immune score. And 3 would mean a high cutoff, which is more than equal to 50% TC or more than equal to 10% IC, the tumor cells or the immune cells. So basically, we'll be talking about this subset in the subsequent slides more. Next slide. If you look at the baseline characteristics, they were well matched, whether it was between the arms, that is atezo or chemotherapy, or whether it was between the PDL1 subgroups. We can see that both the histologies were there. Non-squamous histology was about 65 to 70% across the arms. The squamous histology was about 20-25%. And most of these patients were young patients less than 65 years of age. There was an Asian population of about 15 to 18% is also something which is important to note. Next slide. So this is the result that we're talking about. The primary endpoint of the study was overall survival in the IC3 and the TC3 population, which is the high PDL1 subgroup. And you can see that the Kaplan-Meier curves for overall survival, they are separating widely, with the tail of the curve becoming very flat for immunotherapy. And look at the hazard ratio of 0.59 with a p-value of 0.01, which is certainly So we had overall survival of 20 months with immunotherapy, whereas it was 13 months with chemotherapy, and it was statistically significant. If you look at the 12-month overall survival, it was 65% in atezo arm, whereas it was 50% in the chemotherapy arm. So certainly it was a trial where the primary endpoint of overall survival in the high PD-L1 population was. Next slide, please. If you look at the OS in the key subgroups, most of the subgroups, if you can see in this forest plot, they actually favored the atezo arm as compared to the chemotherapy arm, be it the squamous histology or the non-squamous. Non-squamous had more number of patients, so the confidence intervals are on the left of Unity. If you look at the Asian population, there also the diamond is on the left side of Unity. And if you look at all the age groups, most of the age groups also benefited. Next slide. So very importantly, one has to understand that if we have a patient who's an elderly patient, who cannot tolerate chemotherapy, certainly this is an important subset of patients where we can offer atezo monotherapy. Even if the patients can tolerate chemotherapy with a good performance status, if they have a high PD-L1 expression, then there is no need to use chemotherapy. We can certainly resort to a monotherapy of atezolizumab and achieve a better outcome in terms of overall survival. If you look at the subsequent treatment, nearly 1/3 of the patients in the control arm received subsequent cancer immunotherapy. Still, there was an overall survival benefit, and the proportion of patients who received subsequent chemotherapy in both the arms, they were similar. Next slide. This is about the PFS, and PFS also was 8 versus 5, and we always know that the quantum of benefit in PFS is a little less in immunotherapy trials as compared to what it is for overall survival. But nevertheless, this was significant, and we can see the Kaplan-Meier curves separating widely with a significant p-value and a hazard ratio of 0.63. Next slide. If you look at the response rates also were increased, about 40% response rates with a high PD-L1 expression in atezo monotherapy arm, whereas just 30% approximately in the chemotherapy arm. Next slide. So be it the response rates, be it the progression-free survival, or be it the overall survival, atezo actually was a clear winner over chemotherapy in this particular trial, which is IMPAR 110. This is about the updated safety profile. Nothing new really here. We know how immunotherapy works and what are the adverse events, and this is exactly what was seen. Next slide. So manageable safety profile also is another booster for us to, as clinicians, for us to be using monotherapy. And this is the same thing which is seen here. There was less of anemia, nausea, neutropenia with atezo, understandably, as compared to chemotherapy, whereas there was increased of hypothyroidism or transaminitis with immunotherapy. Next slide. So the conclusion of this particular trial is that atezolizumab certainly is one of the promising first-line options for high PD-L1 expression NSCLC patients. This is a positive study with a meaningful improvement in overall survival and progression-free survival in the high PD-L1 expression population. Safety profile is something which was consistent with the other trials, and it was manageable. And if you look at the atezo patients, they had a longer treatment exposure than patients treated with chemotherapy. Next slide. Now coming on to IMPAR 150, and very importantly, this was conducted only in patients who had non-squamous histology. This was a phase 3 study again of atezo plus chemotherapy plus an important VEGF inhibitor, which is bevacizumab, in first-line advanced non-squamous NSCLC. Next slide. So this is the trial schema where it is very clearly mentioned that patients of all stage 4 NSCLC had to be non-squamous histology, and they were randomized to 3 arms basically. The arm which was the comparator arm was bevacizumab plus paclitaxel plus carboplatin, and this has been a standard of care treatment for quite some time in non-squamous histology. Lung cancer with the data of Whale and the SAIL study in 2009, the use of bevacizumab had certainly improved the progression-free survival. So this is what they really wanted to check as the control arm, and what they kept as the experimental arm was the arm B and arm A. Arm A was atezo plus paclitaxel plus carboplatin. They wanted to see whether the switching of bevacizumab to atezo did make a difference, with the maintenance arm being atezo. And the B arm, which was the most enriched arm, was atezo plus bev plus pacli plus car, which is called the ABCP regimen, and which was followed by, after cycles 4 to 6 cycles, followed by maintenance with atezo plus bev. And this was until toxicity or progression. So the important questions that it needed to answer was as whether the addition of atezo to the standard of care of bev plus pacli plus carb made any clinical benefit impact. Is there any improved clinical benefit if bevacizumab is replaced by atezo, is what they wanted to know. Important is that the co-primary endpoints were investigator-assessed PFS and OS in the intention to treat population. Next slide. So this is what we already know about the use of atezo plus bev, how it really does make a difference and improves the penetration of atezo into the tumor vasculature, because bevacizumab normalizes the tumor vasculature. Bevacizumab also goes a long way in decreasing the activity of the stem cells and the Treg cells, and it enables the reprogramming of the tumor microenvironment. Next slide. With the enhanced effect of atezo along with bevacizumab, does it really make a difference, is what we need to see in this study. The baseline characteristics were quite well matched between all the three arms. Important to note is that there are about 10% patients who were EGFR positive, and they had already received the anti-EGFR therapy in the first line, and they were now being recruited as a second line in this particular trial. And there are about 50% patients who had baseline liver metastasis. Sorry, 14% patients who had baseline liver metastasis. Next slide. These patients, they were chosen irrespective of PD-L1 expression. So 50% patients had a high PD-L1 expression, 50% had a low PD-L1 expression, and this is the result screen, which says that there was a significant OS benefit with the addition of atezolizumab in the intention to treat population. We're talking about difference between arm B and C, that is ABCP regimen and the BCP regimen. And we look at the Kaplan-Meier curve, they're separating widely. The overall survival was about 20 months in the experimental arm, whereas it was 15 months in the control arm. There was a delta of 5 months which was there. The quantum of benefit, although a small benefit, but it's certainly a solid, meaningful benefit. Look at the hazard ratios of 0.8. It is reassuring for me as a clinician, and a p-value of 0.01, certainly significant. A landmark OS analysis at 24 months said that 43% of the patients were able to be alive in the experimental arm of ABCP, compared to only 34% with BEV plus pacli plus carb. So certainly an important positive study at that, with the establishing the role of ABCP regimen as the first line in the treatment of metastatic NSCLC. Importantly, it is non-squamous histology population. Next slide. If you look at the response rates, the response rates also were high in patients who were treated with ABCP regimen. Look at the arm B, be it the intention to treat population or the PD-L1 high or low. All the stratifications, if you see, the highest response rates were seen with ABCP regimen as compared to either the atezo plus paclicarb or the BEV plus paclicarb. Next slide. If you look at the OS benefit, it was observed across all the PD-L1 subgroups. That also is quite reassuring. Of course, the high PD-L1 expression had highest benefit, which is something which is understandable. The maximum quantum of benefit was in high PD-L1 expression, but the other ones, even the PD-L1 low population and the PD-L1 negative population, also benefited with ABCP regimen. Next slide. That is why the approval of this particular combination is irrespective of PD-L1 expression. Now we talk about the key subgroups. One is liver metastasis and the other is EGFR positive. Next slide. Like I said, there were 10% EGFR mutant patients. So it could be seen that these patients, all of them had received the anti-EGFR therapies in the first line. Next slide. And it was seen that the benefit of this ABCP regimen was seen even in this subgroup of patients, with the p-value being significantly in favor of ABCP regimen, hazard ratio of 0.59, and the Kaplan-Meier curve separating the median OS being about 10 months versus 6 months in experimental versus the control arm. So this was the first study which actually provided a clinically meaningful PFS benefit in these subset of patients, whereas we know that most of the trials, they actually preclude the inclusion of these subsets. OS benefit in these patients also was seen. If you look at arm B versus C or arm A versus C, B versus C was certainly better, and the OS benefit was also seen. So important understanding is that if we have a patient who is EGFR mutated and has had his share of anti-EGFR inhibitors, and now we are contemplating chemotherapy or for that matter immunochemo, then ABCP regimen is the way to go, because there is no other data set to suggest that EGFR sensitizing mutation patient can be given any other set of treatment. Next slide. The response rates also were higher. If somebody has to say that 70% response rates to be seen in second line in EGFR mutated, we'll take that any day. 70% is what we expect from TKIs, and in there we have a second line treatment having 70% EGFR mutated, which are known to be conventionally not very responsive to chemotherapy. Certainly a very promising figure. Next slide. If you look at the liver metastasis, next slide, we do know that liver metastasis patients have lesser overall survival compared to patients who do not have liver metastasis. Conventionally, not a very promising subgroup, but there also there was an improvement in progression-free survival from 9 months approximately to 5 months, and the hazard ratio of 0.41. Next slide. And not only the PFS, if you look at the OS, that also was improved with liver metastasis patients between arm B and C. So certainly, again, an important subgroup of liver metastasis also improved with this ABCP combination. Next slide. Next slide, please. There was improved response rates as well in liver metastasis patients, something that we really want, because we don't want the patient to undergo a transaminitis phase, which can be really detrimental for our treatment plan. Next slide.
That's a great presentation, but you need to conclude. So last 1 minute.
Yes. So this we have already seen with bulky disease. This also was improved. Next slide. Yeah, you can go to the next slide. So this was the, yeah, we know about the safety profile. Next slide. So the conclusion is that this ABCP regimen certainly is an important active regimen in first line non-squamous and SCLC. Next slide. Now we come to the third and the last part of next slide of this presentation, which is the IMPAR 130 study. Next slide. Which is again in non-squamous NSCLC, a phase 3 study of nab-paclitaxel plus carboplatin with or without atezolizumab. Next slide. Yes, next slide. Can we come to the trial schema? This is the trial schema, which says that in patients who are having a non-squamous histology stage 4 patients, they were randomized to receive in the first line nab-paclitaxel plus carboplatin, or the other arm was atezo plus nab-paclitaxel plus carboplatin. Nab-paclitaxel was chosen so that it provides an alternative potential steroid sparing chemotherapy regimen, and atezo maintenance was given. The overall survival was one of the primary co-endpoints. Next slide. Along with PFS in the intention to treat population, the baseline characteristics, they were well matched between the gender, the race. Most of the patients, they did not have liver mets, but about 15% of the patients did have, and most of the patients had a high PD-L1 expression, about 20% of them. Next slide. So look at the Kaplan-Meier curves. There was an improvement in the progression-free survival from 7 to 5.5 months, which was clinically significant. Next slide. And if you look at the overall survival, this also was improved from about 19 months to 13 months, and at a follow-up period of in excess of 2 years. Next slide. Look at the forest plot. Almost all the subgroups, they had benefited. The maximum benefit was seen in a high PD-L1 expression, but irrespective of PD-L1 expression, there was a benefit. Next slide. But there was no benefit in EGFR and ALK positive patients, very importantly. But ABCP regimen, as we saw, definitely had a benefit. Next slide. Overall response rates were also. Next slide. This is the safety profiles that we already know. Next slide. So the conclusion is that this was a positive study of the use of atezolizumab in the first line NSCLC. It demonstrated a superior PFS and a higher response rates with an overall survival also, which was significantly better. Both the primary endpoints, they were met, and atezo plus chemotherapy had a consistent safety profile and a new important treatment paradigm option for the treatment of first line metastatic NSCLC patients. With this, I thank the organizers for having me here, and back to the organizers. Thank you for your patient listening.
Dr. Sudhir, you're there?
Thank you, Dr. Vivaya, sir. Hello.
Yes, we can hear you, sir. Yeah, go ahead, sir.
Yeah, thank you for such a nice academic this night, and thank you so much, Dr. Naresh Soman, sir, for giving me this opportunity. Now it's time to the concluding remarks and take home message from sir.
So thank you so very much, everyone from the organizing team, all the eminent speakers, faculty, chairpersons for the valuable contribution. A great day, a great learning for everyone. We request you to please join us tomorrow evening at 5:30 p.m. To have the another sessions. Thank you so very much. Have a great day and a great evening. Please close the session. Thank you.